This is our August, I don't want to say commissioner meeting, Central District Board of Health meeting. I'm going to call the meeting to order and we'll have roll call. I think we can kind of look around and see everyone is here, but Dr. Call, you want to take a formal roll call or is that good enough?
For this, it's fine, but for executive session, you need to roll call.
Right, I know that for roll call. So far, the only person we're missing is Dr. Cole.
Dr. Young, excuse me.
And Dr. Young, gosh, good catch. Yeah, and she's texted that she was not available today for medical issues, so we do have a quorum, so we're gonna go ahead and continue on. The next agenda item is an action item. This is to approve the agenda, and there's been a couple of modifications to it. I think we, when it was reported out, we had some issues that showed up since then, so I'm gonna make the motion that we amend the agenda to include a discussion on, there's a state here,
Child care.
on child care and CDH participation in the Pride 24 Festival. Do I have a second to approve this amended agenda?
Second.
Got a motion is second. All in favor, please say aye.
Aye.
Any opposed? So the agenda will be approved as amended. Oh, good. Dr. Cole is here.
Good.
Welcome. Good to see you.
Great to see you. Thanks.
Great to be seen. Yeah. So we're kind of down into our third agenda item, which is an action item. This is the Board of Health from May 10th, 2024. Everybody get a chance to look at those. There's no additions or corrections. I'd entertain a motion to approve. Second.
I'll second.
Moved and seconded to approve the May 10th Board of Health meetings. All in favor, please say aye. Aye. Motion carries. Okay, our next agenda item is also an action item. This is to go into an executive session per Idaho Code 74-206-1F to discuss pending litigation. Do I have a motion?
Motion to go into executive session.
Do I have a second?
Second.
Okay, we got a motion and a second by roll call, please. Ada County, Dr. Young, Dr. Cole.
Aye.
Dr. Furch.
Aye.
Boise County.
State your name, aye.
Oh, yes, that's right. State your name and then vote. So let's try it again. Good catch, Donna. So Ada County, Dr. Cole,
Dr. Cole, aye.
Dr. Furch,
Dr. Furch, aye.
Commissioner Tucker,
Clay Tucker, aye.
what are we? Betty Ann Nettleton, what are you?
I has been. Betty Ann Nettleton, aye.
Commissioner Rogers.
Oh, Rogers, aye.
Okay, we got, and Commissioner Hasbrook, my vote is aye as well. So at this time, we are going to go offline and we'll be in executive session until I'm guessing probably around 9:15. You drop all the papers.
You could save some on air conditioning.
That's why I work, Jack.
Hey, welcome back, everybody on YouTube and those in the audience. We are out of our executive session. This time I'm going to announce that no action is taken for the executive. So we're going to move on down to our agenda, which is not an action item. This is a status report on measles in the United States. Victoria, are you here? Hey. Welcome. Been reading about it in the news this morning.
Good morning, everyone. Justin, do you have my presentation? Okay, so as I mentioned, measles has been in the news a lot lately, so we just wanted to come bring an update and kind of talk about what our role with measles came to Idaho. So that's what I'm here to talk to you about, and I'm one of your guys' staff epidemiologists. Next slide, Dustin. So I just want to walk you through what measles is, the current United States situation, what we do to protect the community, and our public health action. Next slide. So just some basics. It's a viral illness, not bacterial. It's vaccine preventable. It is spread through respiratory droplets, and it is very contagious. 9 out of every 10 susceptible people may become ill with the virus. And the virus can remain infectious within the air for up to 2 hours after an infectious individual is originated. So very contagious, something we just are watching right now. Next slide. And then for anyone unfamiliar, it usually causes fever, it causes malaise, cough, it can cause inflammation of mucous membranes, so like in your nose, mouth, that kind of thing. On the slide, you'll see what are called Colvin spots, which are some spots that are in the mouth. It's a characteristic sign of measles. And then I'm sure many people have seen what the rash looks like, but that bottom photo kind of shows you what the rash typically looks like on someone. Next slide. So for when I had to get this information to Donna, the data has been updated since then. So this does say from 8/1 that there were 203 cases in the United States. They did just update it this morning and I checked on that and it's at 219. So it's slowing down. We don't really like to see measles in the United States just because we don't have a lot of it. So people have been watching the situation closely. It has not been in Idaho this year. But it's been in the United States, mostly brought in by people traveling elsewhere in the world. Last year, there were 59 cases, so that's why people were starting to get a little concerned with the numbers. But it does look like it's slowing down, and that's what we all hope for. It slows down, goes away, doesn't become a problem. So next slide. So to protect the health of an individual, we recommend that you talk with your healthcare provider to see what's best for you. There are some people who cannot get the vaccine, so talk with your provider about that and see what's best for you. When traveling, not just for measles, for all sorts of other illnesses, we do recommend talking either with the travel clinic or your doctor again. Some places you're going to encounter malaria and they might want to give you malaria prophylaxis. There's just all sorts of things that they might, depending on where you go, recommend for you. So talk with them.
Question, Victoria. So are we all vaccinated as kids for mumps and measles and all that, right?
It is a routine.
So then if you think you're going to be in the area of measles, you should get a vaccine again.
No, that's if you were never vaccinated.
Oh, okay.
Yeah, if you're fully vaccinated, that you do not need to get vaccinated again. But again, we'd recommend talking with your personal doctor about
And if
that.
you've had measles.
Yeah, if you have
lifetime
measles,
immunity.
you do have lifetime immunity. Yeah, they also, as Jessica just chimed in, the CDC does say if you're born before 1957, because of how prevalent it was at the time, you are assumed to have natural immunity to measles. And then if someone does have symptoms, we recommend talking with their healthcare provider again. If you actually think you have symptoms of measles, we would recommend calling ahead, just to try to avoid spreading it to anyone else. If you call ahead, they can make sure you get back to a room immediately instead of waiting for people. Next slide. Okay, so public health action. If someone does test positive for measles, we are required by the Idaho IDAPA, which I can't think of what that stands for right this second, because we all just say IDAPA all the time. But the Idaho code, we are required to investigate and talk with the individual. So what we do is we just try and do a phone call with them. It's completely voluntary. And we try to ask them things like, where have you been? Because trying to figure out where they might have been exposed and if others may have been exposed in the same way. Offering guidance to decrease the spread. We do offer to contact any of their contacts if they wish. They're more than welcome to contact them themselves and let them know what's going on, but some people just don't want to do that, so we can do that anonymously for them. And then we're there to answer questions. Some of the diagnoses we deal with can feel a little scary. And so our biggest part is giving education and answering any questions that we are able to. If they would like us to talk with individuals who've been exposed, then we can do that. And again, we anonymously, confidentially tell them about the exposure. We offer guidance to them as well about decreasing the spread. We answer questions and provide education specifically on signs and symptoms to watch for. And then we do discuss prophylaxis options because there are some options if you've been exposed. There's IgG you can get, and depending on the time frame, you can also get the vaccine as prophylaxis to avoid getting sick. So yeah, that's
High dose vitamin A.
oh really?
Oh, yes.
That's good to know.
So question is
Hey,
this kind of a concern because of all the refugees coming in from other countries that we don't know if they've been vaccinated or not? Is there any correlation with that?
This outbreak has actually mostly been, outbreak. Some people quibble over that word. The technical definition is 2 or more cases. So the outbreak we're in has actually been linked to a lot of Americans traveling and bringing it back with them. Yeah. That is a concern. Most refugees and immigrants are screened before they come into the country. So that's not the biggest concern with this or other illnesses.
Go ahead, Vivian.
Mr. Chair, Victoria, what our state rank as far as immunization percentage now, do you know? Because we do have a lot of people coming in. You look at the color of Oregon.
Yeah. So last I checked, which has been a while, we're at 80% vaccinated, and then that is just data for K through 12. So
80%.
80%, yeah. We are the lowest in the nation.
So
do we have some of the highest infection rates?
So as far as measles, we haven't seen any, thankfully. And have come to, there was a household situation, was that last year in Southwest District Health? But they were able to contain it to the house. Everyone kind of stayed home. It didn't spread beyond that.
So I guess the bottom line question is, do we have higher disease prevalence as a result of the lowest immunization rate?
At this time with measles, no. I can't speak for every disease that has a vaccine. I don't have all that data right now.
Okay, any more questions? Something to watch?
Yeah, that's all we're doing, just watching.
Especially after school starts.
Yeah, we'll know in a couple of weeks.
Yeah.
Okay, thank you, Victoria.
Thank you.
Okay, our next agenda item is also not an action item. This is a retention and incentive plan that I think, is this a renewal of last year's? We're gonna turn over and see what the plan is.
So just for some background, we had experienced, like pretty much every other organization during the early days of COVID, a really high turnover rate. A lot of things changed then to work remote. And then as we started to bring people back, we and other organizations, employees would seek work elsewhere where they could work remote. So there's just so many variables that impacted our turnover rate. So basically, if we take out like retirements, reduction in force as our funding declined, we would lay off staff as a result of that, or terminations, our turnover rate, and we looked at this in 2021, and that's when we were having the conversations in August. And the first year we implemented this was in December of 22, the retention incentive that I'm going to talk about. To try to reduce it from what was 30%, we implemented it in December of 2022 with about half of that money coming from a public health infrastructure grant, and the other half to do the $500,000, $2,000 retention incentives came from carryover. So as you all know, August, where we are today, is when we talk about carryover and where that money gets designated, which Laurel's going to talk about here in a bit. There's other things that we're going to ask to designate the money to, but this is something I just wanted to talk through because there's a lot of data and conversation about it that's different than paying for an environmental health system, for example. So when we implemented this, and it's hard to tell, right? How is it directly correlated? I think it's probably unlikely. There's so many factors, right? We're getting way more job applicants today compared to even 2 years ago, where we would post jobs and sometimes we would get no one apply, and you have to repost it and offer sign-on bonuses and things like that. So anyway, we implemented December 22, and that year between 22 and 23, looking at that same time frame, not calendar year, not state fiscal year, but the same as we were looking at when we had the initial discussion from basically September through August. It was reduced almost in half. So we were down about 16%. Last year, we did this with board's approval at this August meeting last year. And our turnover rate was about 15%. Now, I will say that's higher than what we had experienced prior to COVID. We'd be 10 to 12% consistently. We also, at that time, tended to lose lower wage staff, entry-level type positions. When we saw this big uptick in 2020, 21, it was all throughout the organization. In fact, as those of you who were around, we had our 3 division administrators retire in about a 1-year period of time. Now, that was a very stressful time for local public health for all the reasons you know. So that's just an example of how it kind of impacted all positions at all levels. So if when Laurel presents the carryover request, this is one of the line items in there that will come again from the public health infrastructure grant and carryover funds, we would implement this on December 20th. So that's the last pay period in December, and employees would see it in their January 3rd paycheck, which we like to do that just because of the timing with holidays and extra debt that people tend to accumulate. And we're proposing less than 6 months of service, $500, 6 months to less than 3 years would be $1,000, and 3 or more years would be a $2,000 retention incentive. You have to be employed at 5 o'clock on December 20th and not have given resignation in order to receive this. So this isn't, this right now, what I'm telling you is not an action item, but you will vote on it here when we go over the carryover designation. So I know staff have really appreciated this. The public health infrastructure grant will be for 2 more years. It has to be authorized by the legislature. So if the board chooses to do it this year, if it doesn't impact those subsequent 2 years, we bring it back next August and the following August, pending availability of funding, both in carryover as well as the public health infrastructure money. So I'll answer any questions, or we can just make sure you understood the lay of the land.
So Russ, I want to make sure I got this right. Less than 6 months here, it's a $500 bonus. Under
Correct.
3, it's 1,000. 3 years plus is 2,000.
3 years or more would be 2,000 and retention incentive. Yep. And that's on the table too. If there's something you wanted to do different, this is just what we budgeted, what we will propose, but it's up to the board.
And Laurel, this is the 139,000 you're talking about in the report. Remember what it was last year?
Last year was, that'll be on the first handout, page 3 of the first handout, 117,000, and it was supplemented with the infrastructure grant to pay the complete cost. This year, the amount that's paid for with the infrastructure grant goes down slightly, so we'll be asking for more before.
So I'm kind of new to some of this HR stuff, but how much market analysis goes into, if any, establishing the 500 for less than 6 months? And then the other question that came up is there any merit basis to these particular bonuses? If you have some sort of thing in your personnel file or, something, are you precluded from part of this? Or?
Mr. Chair.
Yep, go ahead.
So we didn't do a market analysis. I think what we talked about was we wanted to reward our longer term staff. And that's kind of the feedback we often get in surveys and communicating with our teams is we need to create a separation between newer employees and employees who've been with us for 30 years to make it, to recognize them for their commitment to CDH. Probably the 2,000 cap is a little bit of a holdover from what the state allowed back when we were under the Division of Human Resources oversight. That was the maximum you could give. So that's why we selected that, but it wasn't. If you give 2,500, you get X number more employees who are more likely to stay. And that's why I kind of preface the conversation with, I can see from the data our turnover rate has been reduced, but if we didn't do retention incentives at all, I can't say that it wouldn't have been possibly exactly the same. I like the idea because we have the public health infrastructure grant, which actually pays for positions too. But one of the things we built into that and was allowable, that's federal money coming to the state, was to be able to do retention incentives like this. And then we have the cash carryover, which, as you all know, generally comes from salary savings that we realize each year.
So Laurel or Russ, I'm not sure to ask. I'm assuming you take taxes out of this before their check gets written, about 30%.
Not sure what it is based on what the employee earns and
That's a great one.
this is, yeah.
Well, I know a few years back, we had problems with getting people to apply for jobs. And we got to looking at our salary in Valley County, and our base salary was $16.70 for a new employee. We felt like because we're not getting applicants, we need to raise the base up to 20, which we've done for this year's budget. So beginning job now in our county is going to be around $20 an hour. What that did though is it made your older employees inverted, because now you might have a 2-year or 3-year that's not making 20. So it ends up bumping up that scale all the way through. But this is a people organization. It's not trucks and trailers and hay balers and that kind of stuff. It's a people thing, and we got to figure out a way to take care of our people. And really 139,000 is pretty cheap. Pretty good deal.
Mr. Chair, Russ, when do we do our climate survey again?
Mr. Chair?
Climate survey.
Our scout survey.
Yeah, so,
Oh,
and I was gonna, because at the very end, just director's report, my review is coming up for the October board meeting. So we usually do that in September. And that's one of the questions we talk about. Are you paid fairly for your job? And actually, we had pretty good response last year.
We
That
did.
tends to be
We
the
did.
lowest,
Yeah.
the most negatively rated statement for which you respond to. But yeah, so that's when we'll do that, and then that'll be provided to the board. The board will have the opportunity to do the reviews, and I'll talk about that at the end of the agenda. But one thing I wanted to just mention about salaries is that, like what you're doing, we have had an independent review. Robert Grifford did the review 2 years in a row. We actually use the state job classification system, and we use their pay ranges. And they've actually made some pretty aggressive adjustments to move those pay ranges the last couple of years. I'm sure because of inflation. I would expect that'll slow down. Historically, there were years where there were no adjustments to the pay range. I mean, you still move up and get merit increases short a recession, which we experienced back in 08, 09, 2010. But honestly, you all have been very, very supportive of pretty good pay increases. And that's when we do the merit adjustments, if you're a chief performer or high performer. And I can just say that's been really helpful. I think that helps with retention also, is because we're competing with a lot, state agencies. We're competing very directly with healthcare in our area. And so I've certainly appreciated that. And I know the staff have too, that we've been able to give raises. And the last thing I'll say about it's been good, right? Our revenues are good. We've brought in a lot of new grant funds. Our budget's over $18 million compared to bumping along at 12 and 13 million for quite a few years. So I think we have to take advantage of the good economics when we can, because that won't last forever for sure.
Well, and I think it's really important because years ago, the counties, kind of like school boards used to do, maybe they still do, I don't know. But every year you work, you got an automatic 3%. And if you got certified or you took some CE class or something, you went down 4%, which sounds great, but it's a budget buster because there's going to come a year when we don't have the funds to pay that automatic raise. I like this idea where we vote every year. Hey, we're going to do a bonus. We got the money to do it. Let's do it. Or there might be a year where, sorry guys, we don't have it. And I don't think that's going to happen for a while, but you never know.
Mr. Chair, I like that construct. Do it when you can.
Do what you can.
Because I mean, running business for so many decades, you have good years, lean years, good years.
Absolutely.
But the employees understand. And then they're very appreciative. And to the point of the whole thing is retaining those good employees is the goal.
Yeah. And I think where we might get tripped up is if we have a recession and we lose value at the county level, value start going houses, all that stuff. There's less revenue coming to the county. Since we're county funded now, we're going to hear about that right away. Hey, we can't keep doing this, or we've got to cut back 10% or whatever that is. So you're forewarned, but that's going to make our decision really for us what we can do as far as salaries and all that stuff. Very county dependent.
That happened, remember?
I've been through that, and I went through on a school board where we had to do a RIF program on tenured staff, and yeah, we had attorneys sitting at that table too, but it worked. It worked, and sometimes you got to go backwards before you can go forward. Any more questions for this? Not, we're going to move right on. Laurel, you're up next for the 2024 year-end financial reports.
Got the handout up on the screen. So at the August meeting every year, I like to start by thanking Conan and his team for the work that they do throughout the year. At this time last year, Conan had only been in his role for a few months, and we'd asked him to do all the year-end calculations, do the transition to Luma, everything that he had to go through, and he was just completely new to it. But over the past year, he oversaw the transition to Luma, figured out the reporting that I've been able to provide to you at each board meeting, even though that took a lot of manual calculations and moving data from the system to spreadsheets that he created. In addition to that, he had one team member retire this year and one resign. So he's hired and trained new staff and done all that while managing the transition to Luma. So really proud to be able to work with him and the finance team. And finance year is easy, but he made it look easy this year. So very appreciative of the work that they do. And the culmination of that work is in the year-end budget report, which you see up on the screen. So we ended our fiscal year in a comfortable financial position, which we saw throughout the year. Not going to be anything new in this report that we haven't talked about in the other board meetings. Our total revenue came in greater than we had budgeted at about 104%. And then our total expenditures came in under where we budgeted, about 95%. Last year, I was look at last year's report too. Last year, our revenues had come in at 120% and our expenditures were only 94%. So we had a huge gap. This year, much closer to what we budgeted with just that 9% gap. It does still give us a carryover balance. We'll be talking about that next. But getting a little bit closer to what we planned year over year. So that's good news for us. Looking more closely at our revenues for the year, you see that our fees came in at about 95% of what we planned. Community environmental health was right on at 100% of where they planned to be. Family and clinic services was a little bit behind their planned amounts. Throughout the past year, we're still working on some billing details with MedMan. Our contracts were slightly under what we planned, but of course we received much more in the other category, mostly through the opioid funding, so that balanced it out. And then for FY25, we're hoping to be a little bit closer with what we are budgeting for the receipt of opioid and other funding so that we're not so far off, but a lot of that funding we get notification of just before we receive it, so we don't always know to be able to plan for it. But we'll be tracking that this year. With our interest revenue and county contributions, we ended up at a total of 104% of budget.
So when do we get the rest of the county?
We may have already received it. It just isn't reflected in this report.
Okay.
If not, we get it this month. Looking at expenditures, our personnel came in at 91% of budget. That was the trend that we saw throughout the year, but that did give us about $1 million savings in personnel. So that's a significant part of our budget. Our operating costs were very close to where we planned to be. Capital was over. We talked about that during the fiscal year. We had some unplanned facilities costs and then some unplanned IT costs, which included upgrades to all of our conference rooms and the outlying offices to Teams rooms so that we could, for example, have the McCall meeting smoothly with no tech issues. Our trustee benefits was a little bit over the planned amount, and that varies depending on what contractors are providing services for us. And then overall, our expenditures came in at about $954,000 under our planned amount, which brought us to 95%. And on to page 2, we see that our fee revenue compared to the last couple years is pretty close to where we have been, a little bit under for community and environmental health and trending upwards for family and clinic services. And we anticipate that trend continuing upwards this fiscal year for family and clinic services. Our contract revenue was down some last year, but as we know, our other funding is where we received a lot of that additional funds instead of in contracts. So that was up this past year. So fees compared to what we planned, like we talked about on the last page, just slightly under, less than 5% under budget. And then our contracts were behind budget because of where we ended up receiving those funds. And one of the things we changed on this report, if you look at the very last column on page 2, our under and over is backwards. So if you see a positive number there, it's actually under. And if it was a negative number in parentheses, that would mean we're over. So when you look at this year's budget to actual report, we corrected that. That was a holdover for many years. I'm not sure how that ended up happening. So if you're seeing positive numbers there, that's where it was actually under, and then the negative numbers are over. So we have corrected that, but that's why you see those numbers there for our revenue and expenditure report. Then moving on to the cash balance statement. Yes,
I mean, on our sewage and land, why are we down with everything, we see going on?
Yeah, some of that, and I can talk to Conan about this to be sure, but You'll see when we look at the July report for this fiscal year, the first month of fees for both community environmental health and FCS didn't get categorized properly because of LUMA. We think that we corrected all of that by the end of the year, so these numbers are accurate, but we know there were issues in reporting fees in the correct categories, at least through the first couple months of the year. So I believe this is closed and that we've fixed the problems, but there may still be some reflection of that, the miscategorization of some fees. And other than that, I'm not sure. It could have to do with efficiencies in our inspections and the way the inspectors are doing the work. For FY23, we did have some of the inspections were being done by higher paid staff that had to travel a lot, so that inflated some of the numbers.
Well, I mean, if you look at like childcare licensing, 22 is 35, then it jumps way up. So I'm assuming that must be some LUMA issues now. It's back to kind of normal where you certainly didn't have that many more childcare fees in 23, did you? And then
Mr. Chair,
sure.
I can also explain that in that fiscal year, Central District Health was also assisting covering South Central District Health in that area.
Oh,
And so we accumulated more fees as we were covering more childcare facilities.
We were going to Twin Falls, weren't we?
We were
Yeah.
going to Twin Falls for a number of months as they were experiencing staffing and issues, and we were helping to cover some of those facilities and therefore gauge some of those fees that were.
so those fees came to us, Curtis, instead of the district.
Correct.
Ooh. They get that position filled?
It is currently filled, yeah.
Filled now, okay.
And then moving on to the cash balance statement. Look at the bottom line of that page, we are left with an undesignated cash balance of just over 867,000, which is a lot, but it's closer to budget than we've been for the past few years that I have been doing this report. The top of the report shows that our total FY22 year-end cash balance was just over 11 million. When you reduce our cash balance by the total of our reserve funds and special projects, that left us with that undesignated cash balance of just over 867,000. To summarize the special projects that the board approved at this meeting last year, our EH system contract was awarded to Acela, and they are a company that does some of the inspection programs for the city of Meridian and Boise. So they are familiar with this area and what we need for our inspection software to include. So the request there that is mostly unspent for 150,000 will be one of the things that we are carrying over as a request, with a request for some additional funds as well. And just as a reminder of why there was the change in that project, at the start of last fiscal year, our plan was to do this project in-house to upgrade the system that we have been working with, that was built by a contractor, and we're the only ones that use it. It's way past end of life. It's not compatible with current browsers. So we're planning to just do upgrades to it. But when we did a complete analysis on it, we found that that wouldn't be sufficient for what the needs of the program are, with the functionality that we need, the wraparound services that we need for it to be easy for customers to use when they are applying for permits and going through the application process. We really needed a product that's more than what we could build in-house. So did that analysis, decided that, went out to bid, and Acela is the company that we're finalizing the contract now. Curtis has been having a lot of back and forth just even through yesterday on finalizing the scope of work to actually get our signatures on the contract, but the bid is complete and we've decided on which company we're using for that.
Question. What's the annual maintenance for that new software? Because
The
that,
annual fee is going to be 75,000 a year. About the implementation costs are more than that, which is why we'll be asking for more than that 150,000 when we go get to the carryover request. But that includes getting ahead of myself, but that includes a data migration for all of the years of data that we have in our old system, allowing us to get off of the system that we use for that, which is Laserfish. So we'll no longer have that fee that we're paying for as an agency. So there are going to be some cost savings with programs that we're using now to do the work in the old broken system that was built in-house. But the cost to implement and get everything migrated over, get the training, get the modules built just for us, get our forms that we use into the system in a way that the customers and staff can use it. It's a significant amount of work. That I actually brought their bid with me. It's 80 or 62 pages worth of what the work includes when they begin doing it for us, because you don't realize how extensive the work is, even just the migration itself, until you see what the companies that do this actually do.
I know the counties are moving to Tyler. A lot of our functions, boy, is it not working. My question is, so our storage is gonna be then in the cloud if we don't have Laserfish? And you could legally do that because the counties have to have an in-house system. Plus they can still store in the cloud for security.
Yeah,
We
we
have to do this.
talked to them about security and compliance, and it meets all the standards that we need for both.
75 grand a year, a lot, but it's a big change.
Our retention incentives that we also just talked about were completely spent out. And then as board's well acquainted with, we decided not to proceed with that, with the medical van purchase. So the remainder of those funds were left untouched.
So are those, that 100,000, is that in the cash balance at the end?
It will be, yeah.
So that's actually 967.
Well, we'll be asking for that to move over into new projects when we get to our carryover request, but it was a part of the untouched
So we're not
funds
doing
for
that,
this
no.
year. Not the medical van, no.
I guess.
It's not.
So look at it.
Okay. Any questions? Where on here, I think it's the third page for it, is our interest income. I'm sure the LGIP and this much money, we need to get it in some kind of investment account.
First page,
First page,
uh,
missed that.
small print in the revenue section under county contributions, interest
There it
revenue.
is. Wow. For $500,000. That's good. So we could take a hit and get through it if we get a hit. Okay, no more questions? We'll move on to the next item, which is an action item. This is to discuss and vote on the cash carryover designations. I'm assuming, Laurel, you're doing this one?
Thank you, Mr. Chair. So as most of you know or remember fondly, I'm sure, annually after the close of the prior fiscal year, Board of Health assesses the cash fund balance and makes fund designations for the current fiscal year that we're in. That's by policy. Our policy lists 4 categories for reserve designations. We've got our special projects or carryover projects. Those are approved as determined appropriate by the board. We have our personnel reserve, and that is to save funds for the year which has the 27th pay period. That occurs every 11 years, and it will be in 2028, fiscal year 28. We have our operational reserve, which we set aside for cash flow needs for emergencies. The board has set a preference that that be held at a 3-month operational level. So each year that our budget increases, we ask for an increase there to meet our 3-month cash flow needs should a catastrophic emergency occur. Our capital reserve is for major facility related costs and capital planning, and the board's preference there of late has been to leave a $1 million balance there for anything that might happen, again, catastrophically, that we need capital funds for. So the top of this handout shows the calculation of our available cash, which we just saw on our cash balance statement. That amount is just over 11 million. If you look at our cash on hand for this year, we increased that amount this year to give us more flexibility if there was needed for any pay issues that happened because of LUMA. We haven't needed to touch that, but with the board's approval, we did increase that cash on hand amount in case we did. And then you can see the list of our restricted or committed cash.
Some of those things are funds that were allotted for last fiscal year that didn't completely get spent, that we still have designated or obligated to specific activities there. All of the things that have ARPA at the end of them, the Ada County ARPA that you see there, those funds all end in December of this year. So we've received them already, but they're set aside for specific activities over the next few months. Our state home visitation, our WICC, and then we have our FY 2024 encumbrances. And that's new in LUMA. Basically, that's for invoices or requisitions that we received in 2024, but did not get all the way through the processing part of LUMA. So we know that they should have been attributed to FY 24. We want to set aside for them so we can pay for them. So that's what that encumbrance is. But that's a new line item for our restricted committed cash. So when you take out all of those things, that gives us an available cash balance of 6.7 million. And with that, we'll move on to what we would like to do for our special projects and our carryover designation. So as I mentioned during the last report, our environmental health system upgrades for the implementation costs and our year one costs are pretty significant, close to $300,000. And that will get us all the way through the total switchover, all of the data migration, all of the licensing for all of our environmental health inspectors, the CSRs who need to access the system, any of our support staff, and all the year one costs. So the implementation training, full month of support after implementation, and then all the licensing and access that we need within the agency to function in the system. Realize that's a hefty price tag. It was comparable to the other bids that we got in, and with our team of subject matter experts, they were still the chosen vendor, even with those high year one costs. And then annually, it'll be about 75,000 for the first 5 years. We'll already have locked into that price with them as the contractor. Next on the list is the employee retention. So we've got 139,000 that we're asking for employee retention there. And that is it's over half of what we need to do our retention incentives. 91,000 will be covered by the infrastructure grant. For retention incentives at the levels that Russ discussed when he went over what we're planning to do. So there is the ability to change those amounts if we needed to, but that's how that breaks down. The next one is a request that's a little bit atypical for what we usually do for our carryover or for our special projects request. And this is for CDH staffing needs. So typically we don't request staffing needs in carryover funds because they're one-time funds. But the positions that we're requesting here are positions that we either hope to continue with grant funding or through generating fee revenue. So those positions include 0.7 FTE of an outreach coordinator, which is currently funded by a grant. The grant ends in October. We're hoping to get a second round of it, but we don't have it guaranteed yet. So if that grant doesn't come through, we'd like to fund that role through the end of the fiscal year.
So is that like a media outreach kind of stuff or what?
No, she is, she's done WIC outreach. So for the
WIC.
first time since I've been here, and maybe since Russ has been here too, this past year, we saw the biggest increase in WIC participation that we've seen so far, 8% increase. And we believe it's largely due to the outreach work that this person has done. So have a strong agency interest in retaining her and making sure that that work continues because there's still a huge gap of WIC eligible families out there that aren't participating yet. So very strongly would like to be able to, whether we get the grant or not, keep her on the team and continue to see those kind of increases. There is a half FTE request for a health educator who's also grant funded, and that grant runs out in December. Again, we're hoping to get another grant to substitute or to pay for that, but we're not sure that it will happen. So requesting continuation just through the end of the fiscal year there. We would like to increase our team by 1 FTE with a behavioral health provider as well. We currently have 1 behavioral health provider on staff, and she has just in the past few months gotten up to a full caseload. And the need continues to exist there for another behavioral health provider. This position, depending on who we have them seeing, how the roles it's being used, can be partially funded by our opioid funds, but we'd really like that incentive fund to get the position started, and then be able to generate fee revenue and continue it with opioid funding that we receive as well. So that's the plan for the ongoing funding for the behavioral health provider. And then the last positions that we'd like to request some carryover funds for are 1.5 home visitors that will be working for the Parents as Teachers program. They currently have a waiting list in Ada County for the Parents as Teachers program. And we would like to have a half-time home visitor in Valley County, which we don't have a waiting list for yet, but.
Have you had anybody apply? I know you guys were looking.
We have not had anybody, we haven't posted the position yet. We have some people that I believe we've had conversations with who are interested in it, but until we post the position, we wanted to make sure we have the funds for it. We can post the position, and we hope those people, I think we had some references from you, will apply. So that summarizes the positions for the CDH staffing needs. And again, if we get grant funding, some of that money would go back into being undesignated. If we don't, it would just go through the end of this fiscal year. We're not asking for staffing needs on an ongoing basis or just planning to add these people indefinitely to the team unless we're either getting grant funding or there's fee revenue being generated.
When you say there's some overlapping, the opioid could
Yes.
cover some of this, but do you have a guesstimate of how percentage?
I don't have that for you, but I can get that. Not sure
Well,
what we plan.
Is this anticipated enough to cover all those positions that you?
Yes.
Okay.
And Laurel, isn't there more opioid funds coming down?
Yes.
I know you guys are doing much better than the counties are. I can say that.
We're not hurting for opioid funds. That's true.
Mr. Chair, Laurel, backing up here, the vaping at 170, that seems a bit redundant. Could you explain that?
May I ask a clarifying question? Just thank you. Redundant, how or in what way do you see
Why
it
do
as?
we have $170?
Oh, so that's just what's left over as unspent from last year.
Okay.
So we have new funding for this fiscal year. It's already in the budget. This is just they spent out very close to what they were allotted. So we always represent that as a separate line item. They're showing.
Now, does that come under the Millennium?
It came as a separate funding stream,
It was.
which is why a lot of the Millennium Fund, the core activities, so vaping is separate from some of those core activities. So we represent it different in how we code for it. So that's why you see it as a separate line item there.
This is to me a big issue because now we've got grade school kids that the vaping thing is their pen. And
Kidding.
no, I'm not
Grade
kidding.
school?
Grade school kids, yes.
But yes, we have significantly more than that to spend on vaping cessation and smoking cessation activities. That's just what was left over from last year because they do spend so much time and attention working on it. There's very little left over.
So I'm assume you're gonna get to this, but the conference room upgrade, is that this conference room or is that the one in McCall?
This is one of the conference rooms. So that's the last item on the list, conference room furniture upgrade. That was one of the items we added at the end. So I think if you look down, some of the legs of this table, I think it's on that side, have a little bit of duct tape around them. Several of the conference rooms in this facility just have older furniture. Not all the chairs work to go up and down, those kind of things. So we haven't got any bids on that. Have no idea if that's what it would really cost. That's this room and others in this building. Yes.
Mr. Chair, I have another question on that. These tables, I believe, we worked with IDOC for these tables. Are we working with IDOC on repairs for other?
We can work with,
You remembered that?
Yes, I do.
Since I've been here, I didn't know that.
Yeah, IDOC did these, right?
Yeah, correctional industries.
we can do correctional industries, or other contractors on the state contract, or we can go out to bid. So we have a little bit of, ability to determine how we get new furniture, who does it.
Can I backtrack just a
Yeah.
little bit to the staffing needs? So what was the total number of employees? I mean, there's a 1.5,
Go back to my list too.
3.7.
Yes.
3.7.
3.7 employees.
So yes, so for conference room, that is the Armstrong building. And then the McCall office refresh, the line item above that, that's carpet and paint. You're all just there for the May budget hearing and board meeting. That's not a need to have, it's a nice to have. We'd like that facility to have the same standard that our other facilities have. And then the final thing on the list, now that we're working up from the bottom, is the Armstrong bathroom remodel. Some money has already been set aside for that in our regular budget. We've set 200,000 aside for that. We're asking for 100,000 more. Last time we went out to bid on the bathroom remodel, we got a single bid. It came in at 350,000. We decided not to proceed with it at that time because of how much it cost. We're going to go out to bid for it again this year. If we only get one bid and if it's in that same range, we'll be putting it off again. If we're able to get multiple bids, which we anticipate, we've heard that there's a little more availability to do that kind of work right now. We'd like to have a little more than the 200,000 set aside. Again, we haven't gone through the bidding process yet, so we're not sure what that would come in at. That includes all 4 of the major bathrooms in this building. At least 3 of them have had repeated plumbing issues over the past year, leaking toilets, faucets, issues with hot or cold water. We had shower repairs twice over the past year. In the female bathroom, there's gaps between the stall doors. They have old style stall doors. There's paint peeling off. So when we did the facility remodel, we didn't touch any of the bathrooms. So we really would like to be able to offer better bathroom facilities to our customers and staff. And it does include an extensive remodel, but annually now we're putting money into fixing problems in all of those restrooms because they haven't been touched in quite a while. They do get used a lot, yes.
Yeah, on the McCall office, is that EDA compliant now?
Mr. Chair, we requested money in the regular budget for ADA upgrades to all 3 facilities. The main thing we want to focus on there is the push button open doors for staff. Staff in this one and for the public in Mountain Home and McCall. We plan to do that in all 3 buildings this year.
The reason I bring it up is because they're out inspecting right now ADA compliance for all public buildings. And we just discovered that in our 4-H barn, we have a sliding doors are shut and there's a beam across it. They roll and that beam is stopping ADA accessibility into the barn. It's like, the thunk, you know, but it's coming.
Little ramp up and over.
We're probably gonna pay $500,000 in a new building just so we can fix the ADA. That's okay. Any questions on that?
So, yes,
Go ahead.
Mr. Chair. Conference room furniture upgrades. We were talking about this room, but are there others in the building that, because as I sit here, I envision this having quite a bit more mileage on it. This kind of furnishings, but I haven't been in the other conference rooms. My mindset is with taxpayer money, I'm willing to live with the little duct tape. I don't see it, but if we can get mileage out of this for another, whatever number of years. But again, my perspective is limited to this room. But I don't know. I'm not seeing that.
Well, I think the other issue is, I don't know if this is ADA compliant doors, but this is where the public can come in. And those are the things that'll get us into trouble.
Yeah.
I can't imagine them spending all of this money on it, but I think we need to.
Well, this line item is for furnishings, and when I look at furnishings, you know, I wonder if that's a line item that should be a priority at this point.
As I look around, I don't think so.
Yeah, go ahead.
So if the desire of the board was to shift that to more upgraded ADA doors and compliance, it would be very timely. We have a new employee starting on Monday who does need additional accessibility in the building. We just got a quote on 4 doors that she'll be frequently using to have that push button open and to move our badge access. So for those 4 doors, that's $11,000. Like that includes the external access. So if it was the board's desire to upgrade additional doors to make the entire building or most of it have that accessibility, enhanced accessibility, that would be
Maybe we
very
just add
beneficial.
to it conference room and ADA accessibility upgrades.
Or take off the furnishings if we would like to do that. That'd be fine as well.
Or you can take out the furniture.
Yeah.
Mr. Chair.
Yeah.
Maybe I would suggest, because Laurel and I talked about that, the number is very high, is to think about how to do this. If we were to include the ADA accessibility that you just talked about and that $80,000, but before we're authorized to actually spend it, bring those bids back to the board, because it may come in a lot lower.
Yep.
And then the board could either authorize us to go ahead and spend that amount under this category at the October meeting, but you're not going to come in October and have new furniture here. Would be an alternative to just striking it completely if the board would choose to do that.
Mr. Chair, I agree with Dr. Kurtz totally. I mean, these are taxpayer dollars we're spending. We need to be responsible here.
So that let's add to the bottom of that one, the board approval.
Must have board.
Must have board approval for the conference room update. That work? Okay, and this is the next one, so we'll need that in the motion.
So if I can clarify one thing, so were you saying $11,000 is what's needed for the totality of these 4
That includes
extra doors?
outside access door and 3 internal doors to have an automatic opener added and to move our badge access further back on the wall. Right now, they're really close to the doors, so if somebody's in a wheelchair, they can't badge it and move back quickly enough for an automatic door to provide safety.
That's not each, that's total for all 4 doors.
That's the total for all 4 doors. Yes.
So, and is that like I don't know what you call it, a mission ready
That
project, shovel ready
Shovel-ready.
project? Or
allows basically this person to have one access point through the facility and have to go through specific doors. It does not include that's the totality.
something that could happen relatively quick.
Yes.
That project could get done. So is there a way of tweaking a motion that would just take 10 grand of this? Or are we saying we don't have the money for that somewhere else?
Mr. Chair,
Yes, go ahead.
we do have the money for that budgeted in the FY25 budget. We have put 50 grand per facility for ADA upgrades. That is a portion of what it would be for the entire facility. We don't have a quote on what it would take for more than 3. We probably, I don't know, at quick guess have 20 doors or access points in the building, with some conference rooms having two, and we have, as you can see, a lot of doors. So that really was the quickest we could get a solution for a person. If we have additional staff with mobility impairments, we'd be in the same spot again of having to figure out how to have needs met.
I think, I don't know, this, my personal feeling is that here's money, you guys put it where you think you need to put it, and this is 80,000. If you needed furniture, you needed a bathroom, you need an ADA, we give them that general authority. I don't think we need to get down in the weeds about exactly where they're gonna spend every dollar. I realize it's taxpayer dollars, but in this case, with an employee that needs ADA accessibility, that should be the first priority.
I'm not
That good?
necessarily quibbling over that. I'm just kind of focused on the furniture. And
I can tell you from experience, these chairs are pretty spendy. We buy them at the county all the time. We finally told her, those are ground guy, buy them from the same source, same company, and then we get a bulk rate. You do it that way, but chairs don't last very long. Hey, this is an action item. If there's no disagreements or everything is answered, are you done? Is there anything else you want to?
One more thing,
Okay.
Mr. Chair. So then, sorry, the reserve fund designations at the bottom. The personnel reserve fund for the 27th pay period includes an increase. The notes of that are all below. As I mentioned, operational reserve fund includes an increase in what we need to get to our current 3-month cash flow. And then capital reserve fund stays the same. That's it. And with that, back over to you for a vote or.
Okay, yeah, this is an action item, so we need a motion to approve or disapprove or manipulate whatever you're thinking.
Before you, can I just ask about the van that we had budgeted for last year? Is that done for now? We don't want to talk about that at all. This cash carry over.
We had enough money to buy a much scaled back cargo van. So we were able to do that within our budget this past year. So we ordered it. We have not yet received it. And it's just going to be a cargo van that is primarily used by the dental program about 9 months out of the year. They pretty much work with schools. That's the bulk of their work in all 4 counties. So I don't know if we have a ETA on that. So we were able to do it much scaled back from what we originally proposed. It's a large cargo van. They can leave their materials in it, not have to cart the chairs and everything in and out every single day. And then during the summer months, it'll be available for anybody to use.
You gotta get logos and all that stuff put on it.
Yeah.
Good.
That original van idea that we had talked about, that's no longer anybody.
Not currently. We thought we would try this first and just through all the conversations we had, reassess. It's not a never, it's just for now. I think we're going to see how this works. The dental program, the oral health program was one of the programs that would have been using it more often than any others. And now we're able to set them up so they're not taking the escapes, the other FARs, and that stuff's heavy too. So it's going to be, I think, really helpful for our dental hygienist, dental support team.
Okay, so, Mr. Chair, and this $100,000 on the van that Laurel addressed, and you said that went back in the cash carryover? And we've ordered a van?
So the van,
I'm confused.
you can explain it, but we ordered the van. We were able to do it out of last year's budget. So we didn't have to ask for any additional funds or carryover funds in this request.
Didn't we budget 300,000 last year? What was it?
It was 100,000 and we asked for more. That's what we kept tabling, meeting to meeting, was an additional amount for that van. But the reason that it stayed on the special project summary list from last year is that we didn't have to touch that money in, as Russ said, it was part of our regular budget, that our fleet purchase
Okay, so
budget.
but the one we ordered, what does it cost?
60?
is, excuse me, I just swallowed my tongue. Is it four-wheel drive, two-wheel drive?
4-wheel.
Good. Okay, any other questions, comments? Not, I'd entertain a motion to approve the cash carryover and reserve fund proposal, or if you have something different.
I would like to just modify, and maybe someone can help me with a motion to pause, the furniture purchasing if the rest of the furniture is, if this is representative of that, and, shift to whatever we need to do, but not necessarily have 80 grand earmarked for.
You want to drop it down to say 30 or something?
I guess I'm not necessarily quibbling over the amount. I'm wondering about the necessity
Oh.
at all. And if we could redirect that money to something that might have, a higher priority than, that access or something of that nature. You were talking about the price of the chairs, and I'm kind of under the impression that the chairs are in fine shape.
Yeah, we wouldn't be replacing these chairs, but chairs in other conference rooms where they're not functional. Yeah.
So maybe a reduction then, if there is a true need. Again, I'm just saying my perspective is based on this room and what we have here.
Suggestion. So what I would offer is that we would reduce the proposed special project carryover designations. You could reduce it by the 80,000. That goes back into the undesignated cash balance, and then we could bring back bids to the board. That money can be moved back into, this is just the time of year we do it. It's not excluded to August. So if we did that, you'd move the 80 into the undesignated, add it to the 19,388, and that's where it remain as undesignated until such time that we can get bids, photos, and whatever else we could offer for the board's consideration at a future meeting. So that motion would be approve it with moving the 80,000 from conference room furniture upgrade into the undesignated available cash balance for now.
I'll do that.
Yeah, then I'll make that motion to do exactly what Russ said, is move the 80 into the undesignated, park it there for a while, and then come back with more specific need regarding furnishings.
And accept the rest of the proposal as presented.
Yeah, so that would be my only amendment to the proposal.
Okay.
And accept.
Do I have a second? Okay, we have a motion and a second to change the $80,000 designation in the conference room furniture to undesignated cash and accept the rest of the proposal as presented. All in favor, please say aye.
Aye.
Any opposed? Motion carries. So at this time, we're going to take about a 10-minute break, and then Dustin, if you could mute us, please, or whatever you got to do, and we will be back here at, let's say, 10:40. Okay?
Thank you.
We on? Hey, welcome back, everybody. We are at our 10:40 agenda item. This is not an action item. This is information on childcare. Are you done or did I miss something? You looked at me like, wait a minute.
One more for me,
10:30.
the fiscal year
Oh
2025.
my gosh, we don't need to talk about that. Forget. Okay, sorry, we gotta go backwards before we go forward, like everything in life. So next agenda item is not an action item. This is fiscal year 25. Financial report. Fiscal year. That's right. You see, I'm thinking we don't start till October 1st. That's right. July is our fiscal year, so Earl, I'll turn it over to you.
Chair. So we are just very early into the fiscal year. This report is just through the end of July, so 1 month in, 8.3%. So it's not a lot to go over right now. Not seeing any trends or anything really that we need to track. We do have an early increase above budget for our incoming revenues. We're at 12% overall. We're seeing already higher than budgeted revenues in our FCS fees. So that's positive to see. That's that trend that we expected to see from last year is continuing upward. And then in our contracts, a lot of that we tend to receive towards the beginning of the fiscal year. So usually July, August, September, we're higher in contracts than the budgeted amount because the budget divides it out evenly over the entire 12-month period. So overall, we're at 8% of where we plan to be for revenues and the same for expenditures. 7% for personnel costs so far. And as we know, that'll fluctuate a little as the year continues, and we'll see if we see the same trend where we're spending less than budgeted personnel, but too early to tell so far. And again, with operating capital and T&B, also difficult to see where the trends might bring us, but below budget in T&B and capital right now and a little bit above in operating. To our page 2, the main thing to call your attention to on this page is what I mentioned that for the month of July for FY24, you'll see that there are no fees represented there. And that's because we didn't, when we were able to track fees in Luma, was past the July time period, and we didn't go back retroactively and attribute any to the month of July because for the month of July, we don't really know what we got specifically. So no comparison there. You can see we're about where we were for FY23 for our fee revenue so far for the month of July. And same thing we saw on the first page. We've got some overages, some underages, but with only being 8% of the way through the fiscal year. Don't really know what that means yet. And we did correct on here so that any positives will show as over and any negatives will show as under. So we won't have to deal with me explaining that over and over again anymore. I don't know why we hadn't corrected that before, but not showing appropriately. And then on the cash balance statement, we will update that for the October meeting to include the projects that you've just approved and update the amount for the reserve fund designation, such as personnel and the operational reserve. So that this will be updated before the October meeting.
Any questions?
Mr. Chair,
Yep.
I use this as maybe an appropriate time or maybe inappropriate time to bring it up, but we talked a lot about this van to get primary care out to communities. I don't want to give up on that idea. We got a cargo van that Russ said is primarily dental. I think we want to keep thinking forward to get some actual primary care out there.
I agree with that.
So
I third that.
That was,
That was the whole deal.
I mean, we did talk about it quite a bit, and I thought we had a pretty reasonable plan. It was more than we assumed from the beginning, but
Well, and I think it's probably more, I'm gonna say more important in Boise County than anywhere else, because we don't have a facility there, so.
Right.
I think, and what's your pleasure? Do you want to consider another van that is just for primary health?
And I like the construct of, continuing to research. I mean, Dr. Furch did a great job of looking at that bigger vehicle, but I still think there's options available. And I've been in so many medical communities over the years that have them, and they're well used. And it's a great form of outreach to underserved areas. So I agree with Clay that I think it's a good idea, not just to, it's still at the front of our minds, not table it per se.
Yes.
I think it has great utility for the community.
And I think we were, and correct me if I'm wrong, Laura, but this was a van that has to be ADA accessible as well. So people can roll in and see the doctor in privacy and all that kind of stuff. So we're talking a little different than just a cargo van. Dr. Furch, any comments?
My initial reaction to that was a awfully pricey adventure. You probably picked up on my theme that if the table still holds up the cups, we can keep using it, right? And is there a way to accomplish the goal at a more palatable, price? And I guess we did some investigating into other motor pools and things like that. I don't know if, as time passes, if things come up and there's options to revisit and keep an eye on the potential accessibility of, the used vehicle that would meet the needs up front for a while and do proof of concept type implementation. Seeing how the dental van does going out into the community, and when they're not using it, can it be used to accomplish some of those same things? So I'm just challenged by the initial, well, where did we end up? $250,000.
I do have a question kind of for Laurel. So if we have this mobile van in terms of like clinic fees, would it be billable and eventually pay for itself? That's kind of my question. And not just be a capital outlay without eventual cost coverage coming back to.
Good question.
But yes, the services that we provide in the community would be the same as the services that we provide on site in terms of that be billable too.
So it would have the opportunity to amortize it.
Well, what I like about the ability is it gets our name out there in the public, in the different counties. I could see lots of senior citizen interaction with this van out front. People would come for whatever their issue is versus going to the hospital and waiting in line and see a doctor there. I think it's a awesome idea. I know it's expensive. It's going to be expensive, but as Laurel just stated, we're going to be able to bill for those issues. I don't think the dental van is going to work because no one can get inside of it if they're in a wheelchair. So we're really looking at a whole different vehicle.
Mr. Chair. So we can do another set of research and a proposal. One thing I'd like the board to keep in mind is that even with the plan for last year, our primary intent for it was to provide more services like health screenings, epidemiological screenings, that kind of thing, more than primary care. So if the board's intent or primary intent would be the provision of primary care, we might have to look a little deeper into who would staff it. The providers that we have on site now are pretty busy. We don't have, we have our epi team goes offsite, our dental team goes offsite. We have outreach teams that go offsite, but for the most part, we don't have our providers going offsite. They do travel to the Mountain Home Small Clinic. So we need to look at a staffing plan to what kind of services we would actually be providing, would be doing it. So I think the proposal will take a little more than just researching the costs. It may even mean another staff person potentially. So I think we would need to really do some additional research and potentially bring a proposal back to the board. If it was the board's preference to proceed with a plan like that, something that Russ and I have discussed is that our operational reserve at a 3-month cash flow level is very high, and the type of emergency or catastrophe that may occur that would mean absolutely no funding to us, where we have to tap into that. We can't foresee what that would be. If that were to occur, we need to lay off staff anyways, so we more than likely wouldn't need to continue to operate in the same capacity for a few months. So point being, if we wanted to designate some of those funds to a mobile medical van and potentially a staff member to provide services from it, we could leave all carryover projects as we've already designated, not touch any of those, and look at whether or not we wanted to designate some funds from the operational reserve to pay for that separately as a different initiative. All food for thought right now, but
Well, I think it's a good thought, but Betty Ann brings up a good point that the rural counties, I think it would really behoove them to have us there more. That's how you build the trust with the public, is to see the name and the logo and see the face. And
Well, and Mr. Chair, if I may, this is kind of where we're going back to the same objective we previously stated. But the move is more and more hospitals are going to be doing less and less inpatient. And that, I think it's a huge opportunity, if not an obligation to us.
any more comments? Yep.
You know, we talked about a van, I'd have to research it, but an ADA accessible camper and a fifth wheel. Because in a lot of rural settings where I've volunteered, we'll have like a camper set up as the medical clinic and pull the camper. So that's another, it may be more budgetarily conscious if there's some ADA adaptations that can be made to some of those campers. Just a thought, I just want to put it out in the sidelights.
Well, I think we really need to make sure that, how do I state this? Even though we may not have staff for it now, I think this is a program or a specialty that we could do mainly in the rural counties just to build our visual.
That's it, build it and they will come construct.
Yes.
I think we're going to be surprised.
You will be, yeah, no doubt. I think you're right.
Yeah, one last comment then. So in order to recoup, billable services, it would require a clinician of some sort with the licensure that would allow for the billing of certain services. So that's, I believe what you're saying is that it would, in order to recoup, it would also require hiring somebody to staff that for a sufficient amount of time during its use to generate revenue. And that wasn't always going to be the case with the first version or iteration of this concept. It was more just, going out and doing essentially non-billable things at that $250,000 price tag.
Brings up an interesting technology question in terms of having, your extenders there, but with telehealth and Starlink, you can do telehealth to that clinic if you have a more complex patient and still have your medical assistants there if you don't necessarily have the provider there. And now that we live in this era, we can do things like that. I'm just adding to the idea.
Well, I think it's something that really needs to be brainstormed. We certainly don't want to buy a van. It's just going to sit out here in the parking lot. move 2 or 3 times a year, that's not gonna work either. So maybe what we ought to think about is asking Russ and his staff to sit down and how could we prove that option? What I'm gonna call roadside medical. I think there's a lot of issues like, hey, we're gonna do an STD clinic in Horseshoe Bend or Cascade or Donley or Tamarack or, places like that. And will be available. You can call and make a reservation. Hey, we've got 20 people signed up. You can kind of fill that.
Especially if you advertise that it's coming.
Yeah,
I just
Absolutely.
worked with Doctors Without Borders in Central America years ago. And people would walk for 25 miles knowing that you were going to be there. I'm not saying.
I'm not gonna walk that.
But-
I'll probably just die.
Just knowing they have access when they generally don't, they do come.
Well, and is a concept, is it something that would have to be in conjunction with the dental, or could it be two separate? It might. Or be efficient to have it separate.
I think if we were to proceed with another vehicle purchase, it would be separate from the dental. We'd leave that pretty much allocated to that program, which does generate fee revenue already. And then, yes, this would be a totally separate endeavor vision. And I'd be happy to bring back a report, a kind of brainstorm report for the October meeting.
Awesome.
Roadside medical, if we want to.
Roadside doc, yeah.
And I think you had touched on last time, the bathroom was essential, having some sort
Oh,
of bathroom
absolutely.
access.
Absolutely.
So when you're looking at those things.
Right. And as Dr. Cole pointed out, there are many RVs with those facilities already there. We just have to set it up. Yeah. Yeah. And the depreciation on those is tremendous. So we may be able to find something at a, reasonable price.
Okay, so you have your direction, I guess. Anything else you need to report?
Yeah.
Good job today.
Thank you.
And now we're going to move on. Our next agenda item is to provide information on childcare and CDH's role. And this kind of came from me. We've had a lot of folks in our area stress the importance of daycare. As everybody knows, a lot of the different businesses are going to 4-day work weeks. And Fridays are a nightmare trying to find childcare for mom and dad who are both having to work, pay the childcare bill, basically. And I was unsure, and after just talking with Russ this last week and some emails he sent, I think we have a pretty good, reliable program, but I think we need to kind of explain it so that everybody understands, especially those folks online, how the fees are charged, inspections are charged, how those are recompensated by the Department of Health. And my goal is to maybe encourage more daycare operators to start a daycare. That's the end goal. And whatever we can do to make that possibility would be something we need to discuss. So I don't know who's going to talk about this. Natasha and Curtis. So I'm going to turn it over to you guys.
Thank you, Mr. Chair. Appreciate the opportunity to be able to share some of the great work that our team is doing in childcare and the role that we play in the licensing process. And I'm really excited to have Commissioner Rogers involved in the conversation as well. I believe she brings insight that will help us and help everybody else understand kind of the process that we go through. With me today is Natasha Perney. Natasha Perney is one of our registered environmental health specialists, as well as our program manager over environmental health on our facility programs, which does include child care facilities, licensing, and certification. So we'd like to spend some time going through this. If you have questions along the way, I'd be happy to entertain those. And don't hesitate to ask those. I've got some handouts in your packet for you to look at as well, and we can describe those and discuss those as we move along. All right, Dustin, thank you. Next page. All right, so I wanted to talk a little bit about some of the things that we do. We are specifically contracted with the Idaho Department of Health and Welfare to perform 4 unique functions for the Idaho Child Care Program. Those functions are to perform health and safety inspections and all the necessary follow-up appointments that go along with those. Conduct any complaint investigations that are reported to the Idaho Department of Health and Welfare, and any follow-up inspections that are necessary as a product of that. We also conduct facility plan reviews. So anytime we have a facility that is new or opening or has recently remodeled and is looking to have their facility reviewed to ensure that it's going to meet all the compliance regulations that are necessary to open, we will conduct that review with them as well. And then throughout the state, we will provide technical assistance and consultation. And that's not just to our child care providers, that's also to our colleagues and peers in other health districts that we work with to ensure that they are performing inspections that are in compliance with the regulations of the state and the kind of the expectations of excellence that we have across the health districts to ensure that we do a fantastic job keeping the health and safety of children in mind. The other thing that I wanted to point out about those 4 unique contracted requirements is the last 2, the conducting facility plan reviews and the technical assistance. These are things that we provide for free to childcare providers. We do that at no cost to them. So that is something that they can request and we will provide at any time to anyone for no cost. The 2 other ones, the health safety inspections and the conduct complaint investigations, we do receive reimbursement for. Part of that comes from a combination of the Department of Health and Welfare and the provider who's applying to receive a certification and license. Also at the bottom of that slide there, you can see the number of childcare facilities we have within our district. Of course, Ada County being the largest at 612 facilities, Boise County, Elmore County, and Valley County rounding out the other 3 at 527 and 16. And then we'll break that down a little bit further for you in the next couple of slides on what that looks like. But the things I wanted to point out is that 660 childcare facilities that at a minimum receive 1 inspection per year. That's a minimum of 660 visits, plus any additional follow-ups that are required and or complaints and their follow-ups, which gets us to roughly somewhere between 800 to 900 childcare inspections on an annual basis.
Are those always announced for the visits or the inspections?
Annual inspections have been announced,
Okay.
and so are complaint investigations.
And then typically follow-up inspections will be scheduled.
Sorry, Curtis, you said for a total of how many?
Somewhere between 800 and 900 annual inspections that our inspectors do.
Think of them as visits.
Okay.
All right, next slide, Preston. All right, this next slide is just kind of an overall flow chart of what things look like for the licensing process. So we have childcare providers who have to go through a process to become certified and licensed to provide this service and receive reimbursement through the state. It is governed and managed by the Idaho Department of Health and Welfare and specifically by the Child Care Program. The Child Care Program then contracts out with various entities across the state, one of them being Central District Health. Another entity being the Center for Disability and Human Development and the Association of Education for Young People. Together, those 2 entities form what we refer to as the Idaho STARS project. Idaho STARS is then contracted to do specific things that you can see listed on that diagram there: professional development, increasing quality, training, developing curriculum, being a resource center for childcare providers, and providing consultation for health as well.
Post health and safety consultants program.
And Idaho STARS is also responsible for the overall certification process. So one of the components of the certification process for receiving an Idaho child care license is to receive your annual health inspection by the health department. So Central District Health is specifically contracted with the Idaho Department of Health and Welfare to conduct that across the state. We then turn around and subcontract that out to the other 6 health districts so that they can do that in each of their jurisdictions. So that's how we fit into that piece. And then specifically within our jurisdiction, we carry out those 4 activities that we previously talked about around the health and safety inspections and follow-ups, the complaint investigations and follow-ups, the plan reviews, and the technical assistance and consultations. Now, keep in mind, that's just one, yes,
Clarification. So the state contracts with Central District Health and then Central District Health is subbing to the other district health?
Mr. Chair.
Go ahead.
That is correct. So
Okay.
as one of the contracting methods that the state has employed has been to contract the entire childcare licensing inspection process to Central District Health. We then in turn develop subcontracts with the other 6 health districts to do that work in each of their counties and jurisdictions. And they bill us and then we bill the state.
Can I just ask why the state doesn't individually contract with the other districts directly?
Mr. Chair.
Why that
Yep, go ahead.
intermediary?
I believe it was for ease of contracting with only one entity versus 7.
Then we turn around a contract with
Correct.
6.
Right.
Correct. And we're compensated for that in our contract with the state.
So Central District Health is the contact, I'm gonna say, for that contract with Department of Health and Welfare. And then we just bring the other districts in and they do their share.
Correct.
Mr. Chair, so another reason would be some agency has to provide and ensure consistent application of rules and regulations across the state. So it's easier for us to do than health and welfare for all 7 districts at the same time. We are the ones that create all the guidance documents for other districts in terms of inspection process, complete investigations, and so on.
Didn't know that we were the contact person for that contract. That's interesting to know, but makes sense. Okay,
All right. The other pieces that I want to touch on today for the child care program would be just kind of the licensing process and then what the Idaho Child Care Program assistance is that people can apply for. So keep in mind that this licensing process is a very comprehensive process that you go through. One of the check boxes that has to be checked off in that process is the annual health inspection with the health department. So that is, we're just one component of the overall process. And then if you go to the next slide, Dustin, I wanted to touch base on some of the types of licenses and the fees associated with those. We can explain those. So on the left-hand side, you see the types of childcare facilities. The thing that I'd like to draw your attention to is where we have the 2 lines that are related to Boise City. There is an exception in the Idaho code that says that if your facility is licensed by either a city or a county of any kind, then you're exempt from having to have a certificate or license from the state. The city of Boise is the only entity within our jurisdiction that has that established. And so they are the only entity that we work with outside of the state to specifically license childcare facilities. So we do have them broken out separately. You can see that Boise City only, those are facilities that are licensed by the city of Boise, but do not accept the Idaho Child Care Program assistance when they enroll clients. Boise City / ICCP, those would be those that are licensed by the city of Boise, but do accept the Idaho Child Care Program assistance funding. ICCP only, these would be child care programs across our jurisdiction that are licensed. Let's see. They do accept ICCP assistance, but are not necessarily licensed by the state. And that is typically due to the size of the child care provider. If they have 6 or fewer clients, then they are not required to register and receive certification and license with the state. But they may still be accepting the ICCP assistance from the state as payment for services that they are rendering. The state-only providers, 102 of those, are those that are licensed by the state of Idaho but have elected not to participate in the Idaho Child Care Program assistance. And then the state / ICCP are those providers who are both state licensed and have elected to receive assistance or receive the payment from the Idaho Child Care Assistance Program.
question.
Yes,
Is that ICCP based on income?
it is. So if you look at one of your handouts, there is a handout called the Idaho Child Care Copay Chart. You can see the second column in that is talks about monthly income. So there's a column for household size and second one is monthly income. And so what a participant will do is apply for the assistance through the Idaho Department of Health and Welfare. Idaho Department of Health and Welfare will do their assessment to determine their household size, their monthly income, and then determine their eligibility for the Idaho Child Care Program. Based on their monthly income and their household size, they will then be assigned a copay for child care. that will be paid directly to the childcare provider.
So I'm a little confused, Kurt. Let's go down, say, household size is 6.
Yep.
Does that mean that grandma and grandpa are taking care of 4 grandkids and that's a household of 6? Or these are outside kids, not family members?
No, this would be, so this, Mr. Chair, this would be if grandma and grandpa or mom and dad and 4 children are applying for assistance at the Idaho Department of Health and Welfare, then their household size would be counted as 6. And then they would determine their monthly income. And then if that household needed to then use childcare assistance, they would then be eligible for up to certain amounts of money in childcare assistance per month per child. And they would also have a copay per month per child that they would pay.
Does that happen quite frequently?
Yes, it is a program that is quite robust with the Idaho Department of Health and Welfare, with a number of participants. I don't have specific numbers on how many participants they have, but I could provide that information for you. Your own.
No, I'm just trying to get it all straight in my head. So you're saying that you could be a big giant family that are all your own kids. Your income's low enough that you could actually get help from the state to take care of those kids.
You could get help from the state for those children to attend a childcare facility so that the
Oh.
adults could work.
Not that grandma and grandpa's open their own facility, but this is to put those kids in a daycare.
Grandma and grandpa may open a facility if they would like to, and if they become licensed and certified and go through all of the processes, then they could qualify to be an Idaho child care provider and receive the state portion of the payment for the kids that they have in care that are qualified to receive that assistance.
Yeah, even on the form, the ICCP form, there, every single child that goes through, they're asking you if you're related to the child. Even if, say, I have a large facility, but if I had, say, a grandchild or I had to have to check that box, yes, I'm related.
So I guess my next question is, would a school qualify if they wanted to open a daycare in a school?
So there are certain exceptions for both education, religious, and workplace settings that may exclude them from needing a certificate or license to be certified and participating in the Idaho Child Care Program. I don't know specifically if it would exclude them from receiving ICCP payments or not.
Bennett Mountain has chocolate because they're an alternative high school.
Right.
I'm certain if they accept ICCP or not.
Yeah, I don't know the status of their ability to accept ICCP, but there are exceptions to the licensing requirements for certain school, religious, and workplace settings.
Interesting.
Meaning like a workplace setting could provide a childcare facility that is in some capacity exempt from some of the licensing requirements, as long as the parent remains in the same facility as the child.
Do they also get exempt from the inspections?
If they're not required for licensure, then they may be exempt from the inspections as well.
Mr. Chairman Curtis, are these figures monthly? That you have on there, is this per month?
That's my understanding.
Well, I would assume, maybe I'm wrong here, but if your monthly income
Yeah.
goes up
true.
or down, then you would be
True.
out of the program or in the program.
Right, yeah.
Yeah, and the Idaho Department of Health and Welfare has specific reporting requirements about that. If your household size changes, if your address changes, if your household income changes, or any of those qualifying criteria change, you're required to report that to the Idaho Department of Health and Welfare. And they will then reassess your eligibility and make any adjustments to your qualification status for that assistance.
So I'm assuming you do this every month.
Yes, even say a client has a bonus, they get a bonus for their job, and their copay could change because when they report that, then that bonus is figured in, even though it's not every month, and that changes that month and it comes back. But as far as the facility goes, we don't track their income. You know, we get the statement from Health Department, this is what they're paying.
Okay, sorry to interrupt. Continue on.
Thank you, Mr. Chair. The table on the right side shows what the current fees are. Now, these fees are set in Idaho statute. They're governed by the Idaho legislature. We do not have any authority to change or adjust these fees. And the fees are set based on the size of the facility. So depending upon the size of the childcare facility will determine the amount of fee that is paid by that facility. So you can see that family/relative providers, those that need to get a license for that or choose a license for that, their fee there is $100. Group settings of 7 to 12, children, $100. Small centers, 250, large centers, 325. And then you can see the number in our jurisdiction for the types of centers that we have licensed that we provide inspections for. Now, this is where things get a little bit interesting in terms of how we collect our fees. So I think as Laurel just reported all of the fee collections that we looked at for the previous year. We have two sources of revenue that Central District Health receives fees from. One is from the provider themselves. You can see those amounts that we collect there. We also collect fees from the Idaho Department of Health and Welfare as part of the contract. Every time we do an inspection, we will receive payment for that inspection up to the amount of $515 minus whatever the child care provider has already paid.
515.
$515 is the amount of money that we are contracted to receive for each investigation or
Is that-
inspection.
So that includes the follow-up?
Correct.
So that's another 515 or the follow-up's part?
No, it is one inspection per year and then follow-ups are just follow-ups. There's no,
Okay,
The chair, we're not paid for the follow-up
Right.
inspections.
we are paid for each occurrence of an initial inspection or an annual inspection and each complaint inspection. So if there are multiple complaint inspections in a period of time for a same facility, we would receive multiple reimbursements for that. You'd have an initial complaint, any follow-ups would be one. And then the next complaint and any follow-ups would be another one that we would receive compensation for. And we receive up to the $515 mark for each one of those inspections, minus the amount of money that the provider has already paid as their fee for the licensing inspection. So for example, if a new provider wants to open their doors and they go through the process of certifying and getting licensed, and they are a group that would have a fee of $100, they would pay that directly to the health district. Once that's complete, we would then invoice the Department of Health and Welfare, and the Department of Health and Welfare would reimburse us an additional $415 to bring us to the total of $515 for the inspection. That covers our cost for our staff, our time, our equipment, our operations, and everything that we need to do to carry out that inspection.
so if it was the large group, the 325, it doesn't go back to the provider, it goes back to us.
The provider would pay the 325 portion, which we would keep. And then the state of Idaho would pay the remaining balance up to 515 for each occurrence.
But this is really kind of a revenue generator well, it's not really because we don't know what our costs are to do all the inspections and run the program.
Well, we do have a pretty good projection on what our costs are and know what our costs are for running the operations and personnel portions of the program. We track those very meticulously through our time accounting and our resource allocation and all of our expenditures. And our intent is we hope to cover our costs, and we're not looking to generate tons of revenue from something that we're doing here. We mostly are just looking to cover our cost.
So when we go through our fee structure every year, which we've already done, I think for this last year, you're considering that fee when you look at, if you had another 200 daycares come online this next summer, you're gonna have to staff up
Correct.
to do that. And then we'll get that report at the end of the fiscal year next year. Hey, those fees are gonna go up or down depending on demand of the system.
Mr. Chair. So these fees that you see on the screen and in the handout here are set in Idaho statute, and we have no authority to regulate or change. Those are set by the Idaho legislature, and we abide by those and do that under our contractual obligation with the Department of Health and Welfare. There is one childcare fee that I don't have listed here that we do have authority to change and manipulate, and that has to do with the Boise City only ones,
License.
the Boise City onlys.
That do not participate in Idaho child care
Correct.
subsidy
Okay.
program.
We are in the process of contracting with the city of Boise to conduct those initial inspections. So when they have a new provider come on that needs to be initially inspected, we will charge them a fee for that inspection. And I believe that fee currently is set at $175. That is the one fee that we have the ability to set based on what our expenses are. And the last 2 fiscal years now, we have set that fee based on the fee setting policy that we've established and that this board has approved, and used our operation and personnel data to calculate our overall cost divided by our number of inspections to come up with a per inspection fee that we have then implemented into our operations.
The important thing that's going through my mind is that I could go back to people that are concerned about this and say the $100 fee for a small daycare is set by code. We don't set those fees.
Mr. Chair, that is correct.
That's where the public is like, we don't understand why we're being charged. Now I have an answer to that.
Mr. Chair, the easiest way to explain that is there is a cost associated with conducting those inspections. Part of that cost is paid by the provider themselves, and that fee has been established and set by Idaho legislature, and it's currently in statute.
And I'm assuming that if the county or even a city or a group of people decided that we want to encourage more daycares in this county, we'll pay that $100 fee for a startup daycare. And that would still qualify that daycare as a fully operational function. There's just somebody else paying that $100 first fee. That's how we can encourage more daycare.
Yes, I would agree that that is one option in trying to incentivize new businesses and or counties and or cities or other entities to incentivize their citizens to be able to do that. Absolutely.
Large centers would be worth the $325 just to get the daycare going. My gears are rolling. Okay, awesome. Keep going.
All right, next slide, please, Dustin. Okay, this one, just wanted to touch a little bit more on the Idaho Child Care Program and provide some information regarding this. This is the assistance program that is available through the Idaho Department of Health and Welfare to families who are eligible based on their household size and income. They can apply for this program, and if they are found to be eligible, they can receive the assistance, which will then help pay for a portion of their child care costs. Assuming that their children are enrolled with a facility that is certified and licensed and able to receive payment from the Idaho Child Care Program, because not every facility is. Some of the benefits of the Idaho Child Care Program is that they will pay what is referred to as the local market rate, which is another handout that you have in your packet. Looks like this. And you can see that it divides all 44 Idaho counties into 3 different clusters. Each cluster then has specific amounts that will be paid based on the child's age and the full or part-time status of the child care. For example, Mr. Chair, you see Valley County is in cluster 2. You can see the age of the children there, and then the child care center versus the group and family center, what the full-time and part-time amount would be paid. Now, the Idaho Child Care Program will pay that amount, but rules stipulate that if the center charges more than that, then parents are responsible to pay their copay plus any additional funds that are charged by the center.
So question, Curtis, this would be more for like a city-owned or a county-owned facility where you're not trying to make revenue, you're just trying to provide a service. But if you're a private, you're going to charge more than that, because I know our daycares are around $1,100.
Mr. Chair, so I believe that any facility would be able to charge their usual and customary fee. And then for any child that is eligible for the Idaho Child Care Program assistance, the state of Idaho will pay whatever amount is in this chart on their behalf. Parents are then responsible to pay the copay amount that they've been assigned, plus whatever is different between the amount charged and what's been received.
Yeah, and I could see that as actually being maybe a future benefit for employees. The county would pay that, or the city could pay that, or the school district as a benefit to them.
Yeah,
Well,
Mr.
this-
Chair, an opportunity for incentives for counties and cities and employers to incentivize parents of children who need childcare. Absolutely, yes.
Mr. Chair and Curtis, what all goes into calculating the local market rates?
Mr. Chair,
Yep, go ahead.
I do not know the answer to that. That is something that is at the purview of the Idaho Department of Health and Welfare. I'd be happy to consult with our colleagues there and get more information on that, but that is something that they have determined.
Yeah, there's quite a difference.
They actually call us.
But
They call us to get the market rates, health and welfare calls, and any daycare provider can give them what they're.
so you just tell them what you're charging and wow, that seems kind of ambiguous.
For ICC, if we accept ICCP clients, we have to update our facilities every month. So that's reported on that as far as how many spots we have open, how many we currently have enrolled, and the price. And sometimes it doesn't fall within this full-time, part-time, depending upon your programming. I would like to know how they come up with their clusters, but
Right.
but it's definitely, and I don't know how accurate or if everybody reports properly. But I would say those numbers are probably low from what people are charging. So I don't know, that might be helpful if health and welfare increased that a little bit, then parents would have that overhead.
They're running off the average income of each county determines which cluster you're in.
Yeah, that's what I'm.
So that's all our data you can get anytime.
I don't know how they determine the clusters.
That's per child per month.
Yeah, that's what they're willing to cover. So anytime it's over that.
Not doing it by calculation, that's for sure.
Mr. Chair.
Yeah,
Curtis.
sorry.
You mentioned if they are the criteria, if they are licensed to be part of the program. So are there some hard distinctions, the criteria that have to be met to be part of the program that don't have to be met if you're not part of the program, but yet still a licensed daycare provider?
Mr. Chair?
Yep.
I don't know the specific differences between the two, but every provider who opens their business for a child care program can make the choice themselves if they want to accept the Idaho child care payments or not. If they choose to, then there would be additional administrative things that need to occur, perhaps some additional licensing or certification criteria that needs to be met. It doesn't make a difference on the health and safety inspection that the health district does. We don't do anything different. We inspect every child care facility for the same things in the same way, regardless of whether or not they're receiving ICCP assistance or not.
Say the difference is training. I know that there's a training requirement for each staff member to have annually to become in that program. And I'm not sure because I am ICCP provider, but I'm almost certain that the inspection, if you're not ICCP, is every 2 years. I don't quote me on that, but I'm not sure.
Mr. Chair.
Yeah, go ahead.
Every year now.
It's every year now.
State license, yes.
And I do it every year anyway, because we're.
Was the case, and I believe it's recently changed to years.
So Crystal, question for you. Where do they get their education? Is there someone offering that?
If you go to the flow chart or that chart there, that's Idaho STARS program.
Yeah, stars.
You could do in-house, like you could have one of their instructors come and provide the training, and do it online. But every facility can track every single employee's training throughout the year. And they each have their own deadline to get certified. And when you're inspection, you have to be in compliance. In fact, even the home based care training, they also, the Idaho AEYC also provides daycare training for that. And I just know that because I offered up my facility for them to conduct that training.
I'm assuming there's a charge.
I don't know if I think it's a free service. The facility could charge. I didn't charge. I donated my facility to it. And they actually provide childcare for that too, or staff would. So there's training all over, but it is mandatory for the ICCP program. You have to have that. Otherwise, it's not. I mean, background checks, first aid, CPR across the board, but the actual training. And there's 2 hours of annual that are mandatory. So there's specific training that they have to do. And then there are other 10 hours on there. They can pick and choose what applies to them, whether it be behavioral or babies or safe sleep practices or whatever applies to their facility the most.
The chair, those trainings are free of charge for providers.
And that is not something the health district does. They have to contact these folks at STARS to get that training.
The Idaho Stars project.
Mr. Chair, and Curtis and Natasha, I'd be interested to get just an update at a later date. Because when you look at these clusters, there's basically a $440 difference between cluster 1 and cluster 3 for the same age child, which is a big difference. Just wondering.
I'll be happy to research that.
I guess the other question is, okay, there are people out there doing daycare that aren't licensed, don't tell anybody. They're just kind of doing it for the family and friends. Is that okay? Or is that illegal? Or what is the process there?
Mr. Chair, and Natasha, correct me if I'm wrong, but there are no regulations or you are exempt from licensing requirements if you're providing care for your own family or to a second degree. So if, such as a niece, a nephew, a grandparent watching a grandchild, those types of relations and familial relations do not require any kind of licensure or certification process. Grandma and grandpa can watch grandkids at will and can do that without licensure.
The chair, but they are eligible though to apply for ICCP subsidy if the parents are qualified.
Well, I guess what I'm trying to get at is how do you handle daycares that I'm going to say are illegal, aren't even signed up or even in the system?
First, we need to be made aware of them. Then we would work with them to provide the necessary education so that they can become licensed and certified. We want to assist them through that process and really walk them through that and to make sure that they're receiving all of the same education, training, and opportunity to be a qualified center of excellence for childcare that all of the other places that we work with are, and that they have the opportunity to reach out and be educated and receive all the training that Commissioner Rogers discussed and receive all the health inspections that we be able to provide to help make sure that the place that the children are spending time in is safe and healthy.
And I would assume that if you're doing this out of your home and you've got a bunch of kids showing up with no license, that your liability insurance is gonna probably pay for any.
I assume that the city that they're in, the neighbors might realize, have a complaint about that, but I don't know.
And that's how we, for the most part, 90% of cases, for the most part, that's how we find out is through the complaints.
So that prompted legislation this year that precluded homeowners associations from banning daycare in private homes. So there's a situation that I'm familiar with where the people, they bought a home in a subdivision and it wasn't, the in-home daycare wasn't precluded, but the neighbors decided after the fact that they didn't like it, so they filed a complaint, and it was kind of going back and forth between the homeowner daycare and the homeowners association that then got the legislator involved, that then got this legislation approved that allows in-home daycares to remain as long as it apparently wasn't an exclusion in the covenants prior to buying the house. And so, yes, I can see where a lot of the awareness would come from complaints.
Mr. Chair.
Yep.
Yeah, absolutely. I think that's probably the primary source where we get a lot of that. And again, really the role of Central District Health is to conduct those complaint investigations or annual inspections in a way that ensures that the facility, whether it's a home in a subdivision or a facility or a center somewhere, meets all of the criteria to be considered safe and healthy for the child to grow and thrive in.
Natasha, how many do we get a year?
Complaints,
Points.
quite a bit. I think, if I'm not mistaken, we receive anywhere between, on average, between 150 and 180.
Annually. How many?
Between 150 and
And I wonder why people are afraid of the system, or they just don't think about becoming licensed, or they're, I don't know.
a combination of both. Sometimes people just not aware. There are specific rules and regulations to follow, and some cases people just simply ignore.
Sure.
But when it comes to HOA regulations, when a brand new provider or a person is trying to apply for a childcare license, in some instances, that is cut with the Idaho Stars, on the Idaho Stars level, because I think those questions are asked during the application process, and provider is forced to figure out what the HOA regulations are and rules. So we're aware of several facilities that started the process and then pulled back the subdivisions they would not allow care facilities.
And that happens a lot at the county. People come to the county all the time wanting us to fight their HOA battles. And it's like, we don't do that. That's between you and your attorney. But the one issue that we picked up on here a few years ago was a new daycare coming in, and 2 doors down was a registered sex offender. And they wanted the county to get this guy to move away. And that was a real sticky one, because he'd been there for a long time. So.
Well, Chairman, the Health and Welfare recently, just within the last couple of months, there's a ratio you have to abide by per, adult per provider per child. They've actually increased the number of kids per provider to allow more spots in childcare in Idaho. I myself don't agree with that because I think quality of care increases, but I don't operate my business on the max ratio. And this might be some feedback for Health and Welfare, that not every facility, large facility especially, is created equal. You could have one that's this size and one that's this size, but they're still licensed for 49 people. So that might be something to take back to say, if they evaluated the facility, like I know at least 2 of ours in Elmore County have pretty big facilities where we would potentially, if we had staffing and work within ratio, could take 10 to 15 more kids, but our licensing doesn't allow for that because it's max of 49.
So what is the ratio for daycare person per?
It all depends on age. Every employee used to have 12 points. And so like say infants are half a point or 2 points. So you can only have 6 infants for 1 care. Whereas school age kids, it's 24 to 1. They're half a point each. So it just depends on age. Yeah, but that would be something to maybe take back to them, because I know their goal is to increase that availability. And I'm not sure decreasing quality of care is right. I understand. But
Well, and the other side of that coin is there's a lot of high school kids that would like to work after school in a daycare We've kind of been investigating whether the launch dollars would help cover that salary for that kid to learn how to run daycare.
Well, we actually have, my facility uses the job shadowing program too. And
Okay.
also the Department of Labor has criteria for some folks that have got their GED or I've gained an employee and trained an employee that way as well. So there are different programs if people are willing to work with them. It takes a lot to mentor somebody. They have to be willing to take that on, but
So, and then one last question, then I'm done. Do you have to buy an extra liability policy for daycare besides what you normally have?
I don't know what anybody normally has, but our insurance is pretty high. We pay about 4,000 a year,
For your insurance?
and it is specifically daycare. They actually come out and inspect as well.
Okay, anything else you guys want to add?
Chair, just appreciate the opportunity to share the information.
This has been really good for me. I'm kind of excited to actually see how it goes, but thank you guys very much. Great information.
Thank you.
Okay, where are we going next? Okay, our next agenda item is discussion and vote. This is an action item on CDH's participation in the Pride 24 Festival. And I think our director sent out some information on that. Well, I'm not sure who's gonna. Laurel is, okay, Laurel, you're up.
Thank you, Mr. Chair. So before we get to a vote on CDH's participation in Pride this year, I wanted to give a little bit of background on the event and let you know specifically what our public health role is at Pride. So for the 2023 event, there are about 70,000 attendees at Pride. It's the biggest event of its kind remotely. The number of participating community partners used to be under 100. This year, it's over 150 vendors and partners and other community agencies. They're looking at maybe needing a wait list for future years because the number of participating partners and vendors has gone up so high. The event's outgrown its original location and now has additional dedicated space in downtown Boise. They'll still be using the space in front of the Capitol that they normally use, but there's some other streets that have been dedicated to space for Pride because of the growth that it's seen. As the board already knows, the event celebrates diversity, offers community resources, provides visibility and resources to members of our community who may be more likely to experience health issues. So our role there this year, one of the things that we are going to be doing is providing sunscreen at all the entrances and at the med tent. We have some big dispensers that we're able to use for that. Last year specifically was really hot. There were issues with sun exposure and dehydration. So like to be able to provide water and sunscreen if we can. We're also going to be offering HIV and syphilis, so with the board's approval to be there, quick screens and referring to appropriate resources as needed. We have a walled tent that we'll be able to do those screenings from to offer privacy. And in talking with the Pride organizer, if we're able to participate, we will have what is typically more than one booth space. It backs up to some open space where they're allowing us to have space so that we have basically the space of what would be two booths for one, just because of that open area behind where they're allocating space for us. So in terms of what information we're providing, and products, we have sun safety information in kids. We have information about our tobacco cessation program, our WIC program information, home visiting program information, suicide prevention, and drug overdose prevention materials and wellness supplies as well. If we can get some space in their med tent, we'd like to be providing our health screens for cholesterol, A1C, and blood pressure. The device that we use to do those screenings is temperature sensitive, so we'll need the temperature controlled space to be able to offer those health screenings. As I mentioned, we'll be using our wall tent for privacy and having that open area of space to back into. In past years, We have been able to provide huge amounts of educational material, information, and had a great turnout and feedback from staff and participants in the event with the public health resources we've provided. So we wanted to get the board's approval to participate again this year in the same public health capacity that we have in past years.
And I think in the past, the fee was $1,500 and that's gone up to 2,000.
That's correct.
Mr. Chair,
Yeah.
for clarification, are we a vendor, not a sponsor?
That's correct as well. Yep, and we have already received signature from the Pride organizer to our policy that our material, our logo will not be used in any promotional material. We will not be listed as a sponsor, and that the contract, they still have some sponsor language in them. So we have our policy and a clause that says it supersedes any listing of us as a sponsor in their kind of standard language that they use for contract. And he's aware of that and has signed that they will not.
Mr. Chair and Laurel, last time this came up, my phone blew up with angry callers. So is it, in that packet, is it plainly spelled out, this is for, diagnostic and educational purposes only?
In the packet that the Pride organizers provide, in the packet that they provide, they have all the options available for vendors to participate, including the sponsorship options. So our contract with them stipulates exactly what we will be providing and that they will not use our logo for any marketing material. But the packet that they provide to all vendors includes all the options that would be available to any vendor, some of whom do want to be included in that marketing and distribution of their logo with the Pride materials.
Go ahead, Mr. Chair. What other events do we pay to be part of throughout the year?
Mr. Chair, so that varies from year to year. Sometimes we do the Western Idaho Fair. We've done Air Force Appreciation Days. I was looking at Crystal, thinking about Air Force Appreciation Days. We've done Boise County events. We do breastfeeding conferences. Anything that there's a tie to either directly to public health or to being able to provide our information and the services we provide to a large amount of people and people who need our services.
So to clarify, have we participated in some already this summer, spring? And do we have others that are on the schedule for the rest of the year? And if so, do you have an example or two of what we're
I don't know if so Air Force Appreciation Day happens in September also. I'm not sure if we're participating in that one this year. I can check with the group. Western Idaho Fair, we have typically participated in. I believe we didn't last year. And I think it was a staffing issue. We'd planned to, and then at the last minute, we're unable to because we had some staffing problems. Yeah. So yes, we have events planned. It is our standard to participate in them. I don't know for sure if we've done others so far this summer, but that's what we see as one of our primary roles in the community and the provision of public health care and information.
Well, I think with 70,000 people at this event, this is a good group of people to be in contact with. Like the Ann said, we all caught heat last time. We're doing a little different this time, but I feel like we still need to be there. It's public health.
Especially with the high-risk group.
13th to 15th of September.
So this is an action item, so we need a motion to approve or not. No motion?
Motion to approve participation as a vendor.
Do we have a second? You got a motion and a second to approve CDH participation in the Pride 2024 Festival as a vendor only. All in favor, please say aye.
Aye.
Those opposed? Motion carries. Anything else on this? Okay, then we're gonna keep right on moving forward. It's like an old clock horse. Next agenda item is an action item, discuss and vote on the employer's portion of social security. I don't know where we are on that. I haven't even talked to anybody about that. So Laurel?
Back to me. Thank you, Mr. Chair. So our options for how we want to use the employer portion of Social Security, if staff vote no, is what we're talking about today. So the staff vote is coming up in September. So we'll know before the next board meeting what staff has voted, which is why we wanted to vote today and what will happen with the employer portion, so that any staff who are holding out to find out what you'll do, will have that information before the vote's due. So at the May board meeting, we had reduced the number of options down to just a couple of choices of what you wanted to do with the employer portion. Those two choices were both PERC 401k options, PERC Choice 401k. One includes an employer match and one does not, or an employee match, sorry, and one does not. So the first option is the PERC Choice 401k without the match. What would happen with that is that either annually, semi-annually, or quarterly is as frequent as it could be, employees would get an additional amount in their 401k. It's already set up for every employee. Not every employee contributes. In fact, most don't. So with the employer portion of Social Security, an equivalent amount of that would be put into their 401k, whether or not they were contributing anything to it. One thing to keep in mind with this option is that those employees must be actively employed at the time that it's paid. So if we do it semi-annually and people leave over that 6 months, even though, they would have accumulated basically some percentage over that time, they would not receive anything in their 401k. They'd have to be actively employed at the time of payout. The other thing to consider there is that there's no impact on the pre-tax contribution maximum. So something to consider as you're voting. And then the other choice, the PERC Choice Match 401k, a benefit there is that could happen every single paycheck if you set up. What would be difficult about that one is that it requires every employee to contribute something, but it can be structured however we want. We get to set what that ratio is, and we would have an agreement with PERC, a contract with PERC on what that ratio would be. So it could be something as small as the employees donating, the employees putting forth 1% and 6% by the employer. We have full discretion over that ratio. It would more than likely be something we'd have to require by policy to force employees to participate in. Another option would be to give them the choice, and then if they choose not to contribute their 1%, you absolutely can't have my paycheck reduced by 1%, they wouldn't receive their 6% either. So if they want to get that 6% added to their 401k, they would need to be contributing something. And it may be difficult for some employees to do. So that's the primary consideration for the board. So your action item today will be to decide if you would like to go with the PERC Choice Match 401k or the PERC Choice 401k that does not require a match.
Okay, questions, comments?
The no match is easier for you. Get that up.
Correct. Yes, much easier.
Well, and I think if we were due the match, of course, our max would be 6%, but I think the counties, it's $1 per dollar match. So if they put in 4%, you would put in 4%. But it's not budgeted for, so we'd have to change the budget if we went that way, correct? If we had a match.
Mr. Chair, we've budgeted to continue to be putting that in Social Security right now. So it's part of what we have budgeted for personnel. So this is if employees vote no only to continue in the Social Security program, then they'll automatically get in their paychecks the 6% that they're paying now out of their wages. And then the employer contribution is what we're talking about now. It can be, we could do 6%, 6%. We could do 1%, 6%. We have the ability to set that up. $1 to every $6, however we want to do it, as long as the percentages work out. But the match option would require, if they want to get anything, they contribute something.
So are you getting any kind of feeling at all from the employees now?
Mr. Chair, we did all, when we asked the employees what they preferred in terms of receiving this directly in their paycheck or as part of their retirement contribution, they opted for the retirement option, but we haven't asked between match or no match what the preference was. We just did what the board asked, which was to find out if retirement and paycheck was the preference.
Sure. And so in lieu of social security, then they lose those credits towards
That's correct.
when they come of age in terms of, I mean, I remember being younger and being enrolled, why am I paying all this money? So if they opted out for it, they may not realize that when they do, not the social security fee there when most of us retire, but if it is great. But, yeah, fingers crossed. So I just want to make sure that they're aware that from a career point of view, whether they're working here or elsewhere in the future, that if they have non-qualifying event orders, they're not going to receive their social security.
Mr. Chair,
Yep.
When we did the information sessions on it, they did a really good job of making that clear. Dr. Furch, I think you participated in one of them. They went over that. Social Security Administration was here to provide that information. The State Controller's Office provided that information as well. And then Percy presented this one leg of the three-legged stool that each portion of this is only a part of what you'll need to retire comfortably. So I believe there's a good understanding of that.
Well, I think from our last meeting, my inclination was to definitely go, and I think I made one of the motions to consider the Percy option, and then the one that was the least administratively burdensome on the district, and how we refine the detail of that, I guess we need to talk about, but that's the direction that I seem to think would be.
Well, I would assume the administrative part would be fair, just as simple as we doing the social security withholding every month too. So it's really, that's what, 7.65%.
6.2, and then there was the other.
1.45 on top of that.
But I think that still would be withdrawn. It's a 6.2% that would go.
State and it's federal.
And Mr. Chair, in terms of what would be least administratively burdensome, as Commissioner Tucker said, that first option without requiring the match would be the easiest. Every employee already has 401k account set up, whether or not they contribute to it. And this would be just something that would be done basically on the back end of when that contribution was made for them. For the match, having to get policy in place, requiring employees to do the match part of it, it would be probably difficult to get instituted and get in place. For new employees coming into it, be fairly easy to set up, but for our 150, 160 staff that we have, there would be some administrative burden to getting it set up.
And budgetarily, we're committed to 6.2% anyway. Social Security, so it's not gonna change the budgeting at all if we just say, here's your 6%. And, tout it and use it retention and, market it, use it for retention language purposes. Here's your 6%, it's going into this account. You're going to get statements from Percy. Here's how it's growing.
There's two things that's coming in my mind. I don't know if you guys have been watching the news lately, but both presidential candidates have come out now saying not to tax Social Security. And now if we're not in that program, of course, you're not going to get taxed on your 401k until you take it out. I'm just thinking of the future. My feeling is that it's your money. If you want to save it, save it. If you want to go and spend it, spend it. It's your money.
That option wasn't included.
That was last meeting.
And they will get to do that with their portion. So
With
this
their
is
portion,
just the employer portion.
Is there gonna be negative negative feelings with, if we don't do the one with an employee match?
Mr. Chair, this was the employee preference to contribute to retirement. Without knowing how the vote's gonna go, it's hard to say, if our staff does vote no, some people may leave over that because they want to get their credits. Some people may be excited about that because they get the 6% increase in their paychecks and then these 401k contributions. It's really hard to say. I think some people will be unhappy both ways. That's pretty fair assumption.
Mr. Chair. On the match, I don't want that to be confused, like we're gonna give the employee who desires to take that 6.2% and put it into their 401k. It would be them required to match in order to maximize that. That's the difference. So it's not like if we don't do the match, they're not getting less from CDH. They would get the exact same amount. It's just whether this board chooses to require an employee contribute to a Percy choice, the 401k plan. So based on the fact he said most don't participate, I think that would be least desirable by the employees because then you're going to make them take money that they otherwise would have been taken out. So administratively, the option for us to put it in is easiest. I think probably it would be the preferred option for staff.
Well, they otherwise, staying on Social Security, they would be paying their half, the employee half.
That's right.
So the question then becomes, do we let them take the pocket change home, or do we require them to, in essence, continue to do what they're already doing under the Social Security model?
Well, and I'm assuming there's employees like me that have been paid Social Security their whole life that are still gonna get Social Security from this group when they retire, but they're also gonna get Percy as well.
Sure.
I mean, that, they're still gonna get Social Security if you've been paying into it. And I'm only got 2 more months, and I'm gonna start wanting to check back, so I want everybody to pay Social Security. Keep that program afloat. But. So what's your preference?
You just go around and vote number one or two.
Yeah, I'll make the motion that we adopt plan number 1 that gives the employees the option to either take their spending my Christmas money home or not.
I second.
So no match.
No match, that's the motion.
No
Everybody
mandatory
understand?
match.
Yeah.
No mandatory match.
Right.
It's still
Optional.
optional.
Okay, we
Up
got-
to the 6%, or no, they can put in as much as they want. Yeah.
Hey, we got a motion and a second to go with the option plan. What's that?
Yeah, I second the simplified version that he said.
I clarified it.
Just wanted to be clear.
Okay, all in favor, please say aye.
Aye.
Motion carries. No match.
And the date that this will be, the 5 o'clock or the 5:30 hour is on what day or what date? Do you remember? Okay,
I have September 17th in my head.
that's correct.
Okay.
That's right. So it's right around the corner. It'll be determined before we meet again. And we'll, if it was a discontinue participating, then we'll be putting this in motion after that vote is, if you don't want to continue, then we'll implement this immediately.
I sent in my ballot.
I got my two.
Yeah, quite a long time ago.
I've returned mine.
Yeah. And it's normally a 90-day, but we had somebody on military leave, so it extended by 60 days. So,
Really?
yeah, but that's why you would have received your ballot quite a long time ago. I think it may, yeah.
Okay, that takes care of that. So now we're gonna go next agenda item, which is the next item. This is review and vote on the resolutions. In your package, you have the existing ones and the new ones. And these are resolutions that go in front of IAB in October. Idaho Falls. And normally, like a lot of these, the old ones are, these are either you have to vote to renew them or archive them, which is basically take them off the table. And then the new resolutions will be ones that you would, to me, are more important, I guess. That makes sense, but I'm gonna let Russ explain it because he's smarter than I am.
But understand the process for sure, is that exactly what Commissioner Hasbrook just said. The first packet resolutions for renewal or archiving, they basically archive after 3 years if they're not renewed. So you'll see the dates here, 1701, 02, and 04. And you say, well, why so delayed? Well, those were renewed in 2021. So now they're up again. The food resolution, interestingly, was revised in 22. So that's not 3 years. So I'm not exactly sure why that one's in here, other than it's been a hot topic every single year since whenever it was first adopted a long time ago. So I guess to be clear, today, you just have these, so you can review them. If you have questions for me, if you wanted to make comments, for revisions, I would provide that back to the host district director in the host district, Idaho Falls. So that's District 7. So there's no vote. It's be prepared to vote in October whether you would want to archive or continue or make revisions, and that can all be done at the October meeting.
Be based on each resolution, will we go one by one?
Exactly. Yep, exactly. Then there's 2 new resolutions so far. This is what we have. The one on solid waste was submitted by Public Health District 7. The one resolution to increase WIC participation is the one I need you to vote on as to whether or not you would like to essentially be the sponsor of that. That's something that Central District Health created, and I'll explain why. So on the solid waste, as certainly our Elmore County board members know, we spend at times, depends on the operation, a whole lot of person hours. We generate no revenue from this program. It's under DEQ, but the districts in Idaho code are named as the ones to oversee operations plan, closure, and post-closure. And quite honestly, and the counties are involved with additional use permits. It's a lot of work. So what the districts have talked about, we talked to Jess Byrne, Director Byrne from DEQ, to try to get clarification on the roles. And I personally like the direction this is going, as far as if we take the health districts out of Idaho code, it doesn't mean we would completely remove ourselves from that work. What it would shift it to is a model like Curtis and Natasha described in childcare, where DEQ could contract with us and pay us to do, you figure out some kind of, especially when it comes to non-compliance issues, that's when we start racking up the hours. And especially with the situation at Mountain Home, and then we're called in to be potentially provide depositions and things like that when it goes into litigation. So personally, I like this resolution. I think it provides us with the opportunity then to negotiate reasonable fees with DEQ if they're the entity that is exclusively responsible for overseeing municipal and non-municipal solid waste landfills. So again, you don't have to vote on it. If you have some specific questions beyond what I just described, Curtis is here to answer those. Mike Reno, you probably know the name. He's the subject matter expert for Idaho, probably beyond. He's off work today, so that's why he's not here. But if you have any questions about this today, Curtis could answer them. And then if you have questions between now and October, send them to me and we'll get them answered.
So basically, Correct me if I'm wrong here, but basically DEQ is gonna be the stronger in a violation.
Or they're not,
You're out of
or they're not. In our case, they haven't.
They have
Strong
stepped
armed,
up.
they haven't strong armed enough. in our opinions, but-
Yeah, Mr. Chair, that's correct. It would essentially clarify the roles of each of the participating organizations, whether that be DEQ, the county, the health district. It would clearly delineate each of the roles and define the relationships that we have with each other so that we're not in a situation where we've been with IRWS and Elmore County where we're confused on who should be doing what. We may be duplicating efforts. We may be unproductive with our time and the resources that we have across the state with the various agencies to be able to conduct the work most efficiently. That's the main important part behind this resolution.
Okay, do you guys want to vote on this? This is an action item.
Oh.
No, not this one.
I know we don't have to, but I just want to make sure we're all kind of on the same page.
I'd like to almost get Mike Reno's take on it.
Yeah, I would like Mike's too.
Mr. Chair?
Yeah.
So I talked to Mike at some length about this because
Uh-huh.
we obviously talked a lot about Elmore County's situation. So he agrees with the language of the resolution. Yes, he supports that. And again, with the caveat or whatever, it doesn't mean we're going to be excluded from that role. But if we do it under contract, we don't have to necessarily be the enforcers. We could say we'll do the inspections and we'll do complaints, we'll take necessary steps to try to get them into compliance and then hand off the enforcement package to DEQ, where the cost really starts to mount. So anyway, there'd be flexibility in how that's structured if we get the health districts out of Idaho code, which is essentially what this is proposing to do. Be legally required to do it versus we agree to do it, but on our terms.
That'll be an interesting contract with DEQ.
Yeah.
So a quick process question about the association meeting. When resolutions come up, are there smaller working groups that address these, tweak the verbiage if someone wants to make a motion to tweak it? Or is it all in the one giant collective
Go ahead.
organization?
One giant collective organization. So there's 56, 57 board members, Board of Health members statewide, all the directors are there, of course. But attendance is probably, I know some of you have attended them regularly, it's probably closer to 40 or 35 board members. And they just pull it up on the screen and make motions and make edits during the business meeting.
And we will be requesting proxies from you guys that are attending. So we have that vote behind us, but normally what happens, Dr. Furch, is that you may modify a resolution through the general membership of this group. And then that resolution can go forward if someone will carry it, like Megan used to carry our resolutions forward, some other senators, legislators. But we'll have to see where they go. See.
Remind me again where it's gonna be this year.
Idaho Falls.
So as an example, it might not be surprising that on the opioid one, a fair number of opioid addictions start from pharmaceutical prescriptions. And if we're talking and emphasizing a public health model, one of the ways of reducing opioid addiction is to emphasize non-pharmaceutical forms of care that accomplish the same thing, but without the possibility of an addiction. And as I read through that resolution, I could envision whereas let's emphasize and put some of our resources into education about non-pharmaceutical, forms of care as a method to reduce opioid addiction.
Sure. Mr. Chair.
Yep.
So in that regard, so these are up for readoption, but it doesn't, that one in particular, you don't have to, you or any of us, you wouldn't have to vote for readopting that as is. You could submit revisions. In fact, if you would like to submit a whereas statement or two for consideration, you could send that to me and I'll get it to District 7 and then they could pull it up on the screen and say, here's a proposed revision. And then the body would either support that revision or not, or readopting as is. So it can be a pretty lengthy part of the business meeting, depending on how many resolutions come forward.
It
And
usually is very.
yeah, usually it's a marijuana once one.
So that would be the process, is to get something to you and then you would submit it.
Or you can bring it up there, just
Yeah,
for
bring it up there.
efficiency.
Yeah.
If you gave it to me now and I got it to them, then when they pull it up, you'll see the underlined in red, whereas non-pharmaceutical interventions, and it would just be more efficient that you can bring up your thoughts that day too.
Proxies, if you're not going, are immensely important. We
Yep.
need everybody's proxy.
Russell, and Don will get that out to us.
Yeah.
What about the WIC one? Do we need to talk about that one?
Yes, we do.
That one's kind of interesting. So let's move on to the resolution in your packet to increase WIC participation in Idaho.
So, thank you. So WIC has been around for over 50 years. It is funded by the United States Department of Agriculture. The money goes to the state. It goes out to the health districts and 2 tribes. And the participation at the tribal level is really low. So it's the health districts that basically administer, deliver these services. It's been really frustrating. I'd call it a bit disappointing to me personally, because I think this is an amazing program, as you can see in all the whereas statements, but noted with number 1, improve growth, low birth weight, reduce fetal deaths, improve WIC women who receive WIC, increased participation in prenatal care, on and on and on and on. The numbers in Idaho and nationally, but certainly Idaho, has been really low and declining in spite of the fact that our population has continued to grow. So for years, we, Central District Health, has made an attempt to work with the Department of Health and Welfare, 2 areas, Division of Public Health and the Division of Medicaid, to do what I have proposed and therefore be it resolved statements without any movement whatsoever. So I'll get into the therefore be it resolved statements in a second, but what the last 2 whereas statements, according to the United States Department of Agriculture, 2021's the latest data, only 44.2% of WIC eligible families in Idaho participate in WIC. So there's a huge gap between eligible and participating. And we rank in this latest 38th. And when I looked at the data, we are declining at a faster rate than most other states in the country. There are states who do really well. And I'll talk about that in a second. The second whereas statement is, the last whereas statement is, WIC is a significant referral source for other evidence-based public health services. That's where we get most of our referrals into our home visiting programs, parents as teachers, nurse-family partnership. And I actually included this just because it's education is a priority of the governor, and child welfare is a priority of the new director of health and welfare, Alex Adams, and foster care and things like that. So WIC is a significant referral source. Home visiting has demonstrated positive impacts for decades, such as reducing child abuse and neglect and increasing children's school readiness and school success. So when you get into the be it resolved statements, these are things that are outside of our control. We talked earlier about the community outreach position that we included in our budget. She has done a phenomenal job, and for the first time in forever, we didn't level it off. We saw an increase of 8% participation, but that work can only get us so far because we don't know who's eligible so that we can reach out to them directly. So therefore, be it resolved, the Idaho Association of Boards of Health Department of Health and Welfare created a database that cross-references Medicaid enrollment with WIC enrollment. If you're pregnant or you have a child up through the age of 4 and you're covered by Medicaid, you qualify for WIC. We don't know who they are, but Health and Welfare does. And it's been 8, 9, maybe 10 years of having these conversations. We've got public health infrastructure grant money that was to work on IT and technology. I mean, we're at the table, like, we want to help, but we can't access it. We have the WIC data for our district. We don't have the Medicaid data. So that's number one. And this is well researched. And if you look at the states that have the best rates, this is exactly what they do. And all I want is give us the names. And it's not HIPAA protected, it's a public health program. We're delivering this program on behalf of health and welfare through a sub-grant. Secondly, is if you guys approve it, if you all approve it, and we pass it on for the association, is every Medicaid applicant who's pregnant, postpartum, or with a child under age 5 be routinely and automatically referred to WIC. Can't be that hard to do. And we have referral, we have software to do that. I mean, there's so many opportunities, and then our WIC staff, our outreach team can reach out to these families and say, hey, did you know? So I would like your approval to pass this on to the other directors, which I will do promptly after this meeting, if you do approve it, and then get this into queue for the October meeting. And then what happens with that is it will go to the governor's staff, which includes Alex Adams, the Department of Health and Welfare. And I want them to realize this is a big deal. We're not talking 98% participate. We're trying to close the gap by 2%. More than half who are eligible don't participate. And it's unacceptable, in my opinion.
I think it's a great resolution, probably one of the better ones I've seen in a while. Just sharing information, even with different state agencies. I think it's a great idea and we should pursue it. Any concerns, comments?
I mean, I'm just surprised that the participation is that low with the inflation on food in the last couple of years. I would think that would make it way up. Yes,
Well, and I
people
think
don't
really,
know.
Clay, what it is people don't know that WIC's available.
They don't know, I guess, doesn't matter.
Okay, so I need a motion then to approve. This is from District 4. This is Russ's resolution to approve advancing this resolution tonight.
So moved.
But a second. Or discussion. I can see
Yeah,
it.
I had one real quick question. So if we vote to approve to move it forward, can we still, like Dr. Birch was saying, send you in whereas modified? Okay.
Absolutely.
Yes.
Yeah, everything can be modified right up until the time IAB formally votes on either exactly as is or revised.
Okay, we'll see you with the second.
Hey, we got a motion, a second. All in favor, please say aye.
Aye.
Aye. Motion carries. And that ends that agenda item. The last agenda item on our list this morning is the director's report.
Okay, the only thing I have is my performance review will be done at the next meeting, which is October 18th. Between now and then, what we do is we do the annual culture survey, which we've been doing for over 10 years. That goes out to all staff. It's anonymous. We collect the information, compile that, which does have people have the opportunity to rate. They're all statements. I don't know how many there are, 40, 38 statements covering a broad range of topics. And so you'll get that. And then the leadership team, who all of my direct reports and all of their direct reports will have the opportunity to fill out a performance evaluation. It is the same as what you all will receive. So Gary will be administering all of this. He'll collect the information, will compile the information and share that with you in October. So just kind of a heads up, but if you want us to do something different or want me to gather different data or different processes, I'm certainly open and willing to do that.
I think this is an awesome review. Our director, you get a lot of interesting comments on it. The last one came back, that gold star, and I thought, oh, great, he's gonna want a raise. Here we go. Yeah, so we're okay.
Yeah.
Yeah. Good news. Any more questions?
I have a greeting to pass on. Rob Howard says, hello, everybody.
Do you see him? You run into him quite a bit?
Well, it involved a hunting tag that one of his family members drew, so that's why I got to call. He said, hi.
That's good. That's good. I'm glad he's retiring.
He said,
Okay, the last agenda item on our list is public comment. Is there anyone online or in the audience that has a public comment? Please let the record show that there was none. There being no further business to this meeting is adjourned. Thanks, everybody. Good meeting.
Yes.
All right, a little longer than normal. I know this is tough to, except for this many hours, but